ಸೊ ಇವತ್ತು marijuana ಅಥವಾ ಇನ್ ಗಾಂಜಾ ಅಂತ ಮಾತಾಡ್ತೀವಿ. ಲಾಟ್ ಆಫ್ ದೆಮ್ ಲುಕ್ ಅಟ್ ಇಟ್ ಆಸ್ ಮೆಡಿಸಿನಲಿ ಒಳ್ಳೆಯದು ಅಂತಲ್ಲ ಅಡ್ವೈಸ್.
If it is advised by a doctor in a limited quantity, in a different form, that is medicine. Workplace is like that, where there is so much of smoke inhalation. Vaping, oh my god. Let's not even go there. And it's not style, it is just death vaping.
So ICU is not just always about machines, it's also medical judgment.
Yes, machines are just there to help us. This world should thank ventilators for being there. If ventilators were not there, there is no critical care medicine without ventilators. See, it's not like we are seeing pneumonias only in old people. We are seeing very severe pneumonias even in younger age groups. Any plastic in the body can cause infections. We are full of bacteria. We are full of
Microbiomes.
our own microorganisms are enough to give us all kinds of illness when the time comes, when the immunity is down. You know, there are 5 important organs in the body, which is brain, heart, lungs, kidneys, liver. If one gets affected, rest 4 will not survive. Imagine a call comes that you are getting an organ today, probably you're getting a kidney today, right? One family made that decision, and that person is like a god to that.
Even in loss, they gave something.
They gave something.
They gave life.
They gave life. You know, one organ donor can save up to 8 lives and can change up to 75 lives.
The minute we hear ICU ಅಥವಾ intensive care unit, suddenly there is an emotion which is filled with stress at times, ಕೆಲವು ಸತಿ ಕನ್ಫ್ಯೂಷನ್ಸು, ಹೋಪ್ ಅಟ್ ಟೈಮ್ಸ್ ಇರುತ್ತೆ. ಇನ್ನು ಕೆಲವು ಸತಿ ಇಟ್ಸ್ ಆಲ್ವೇಸ್ ದ್ಯಾಟ್ ದ ವರ್ಸ್ಟ್ ಕೇಸ್ ಸಿನಾರಿಯೋ ಥಾಟ್ಸ್ ಎಲ್ಲ ಬರುತ್ತೆ. ಯಾಕೆ ಇವತ್ತಿನ ಕಾನ್ವರ್ಸೇಷನ್ ಒಂದು ICU ತರಹದ ವರ್ಡಿಂದ ಶುರುವಾಗ್ತಾ ಇದೆ ಅಂತಂದರೆ, ಐ ಆಮ್ ಶೋರ್ critical care is a place where science actually meets responsibility. The minute we hear ICU, we always think of the worst. But do we understand that concept well enough? Another is a prashni. Machine can support life, but it is always the judgment that sustains it. Who is making those judgments? Of course, we have the doctors, we have the specialists. And especially when it comes to ICU, ಎಷ್ಟೋ ಸತಿ ನಮಗೆ ಗೊತ್ತೇ ಇರಲ್ಲ. ಅದಕ್ಕೆ ಅಂತಲೇ ಒಂದಷ್ಟು ಸ್ಪೆಷಲ್ ಕೇರ್ ಕೊಡೋವಂಥ ಸ್ಪೆಷಲಿಸ್ಟ್ಗಳಿರ್ತಾರೆ ಅಂತ. ಅವ್ರನ್ನ ಏನಂತ ಕರೀತಾರೆ, ಅವ್ರು ಹೇಗೆ ನಮ್ಮನ್ನು ನೋಡ್ತಾರೆ, ಲಾಟ್ ಆಫ್ ಇಟ್ ಟುಡೇ ಆನ್ ಜಸ್ಟ್ ಕ್ಯೂರಿಯಸ್. ಹಿಯರ್ ಐ ಡೈವ್ ಇನ್ ಟು ದ ವರ್ಲ್ಡ್ ಆಫ್ ICU, ಕ್ರಿಟಿಕಲ್ ಕೇರ್, ಎಮರ್ಜೆನ್ಸೀಸ್. ಬಿಕಾಸ್ ಯೂಶ್ವಲಿ ICU ಅಂದ ತಕ್ಷಣವೇ ಬರೀ ವೆಂಟಿಲೇಟರ್ಸು, ಬೀಪಿಂಗ್ ಸೌಂಡು, ಎಮರ್ಜೆನ್ಸಿ, ರಶ್ ಮಾಡ್ತಾ ಇರೋ ಸಿನಾರಿಯೋನೇ ಬರುತ್ತೆ ಹೊರತು ಹ್ಯಾವ್ ಯು ಅಂಡರ್ಸ್ಟುಡ್ ಇಟ್ ರೈಟ್? And most importantly, people who are watching our episode today, after today, I think will be more aware. ಸಡನ್ನಾಗಿ ಮನೆಯಲ್ಲಿ ಯಾರು ಕೊಲ್ಯಾಪ್ಸ್ ಆದರೆ ಏನು ಮಾಡಬೇಕು, ಬ್ರೆತ್ಲೆಸ್ನೆಸ್ ಆಗ್ತಾ ಇದ್ದಾರೆ ಯಾರಿಗೂ, ನಾವು ಹೆಂಗೆ ರೆಸ್ಪಾಂಡ್ ಮಾಡಬೇಕು, ಯಾರಾದರೂ ಅನ್ಕಾನ್ಷಿಯಸ್ ಆಗಿದ್ರು ಏನು ಮಾಡಬೇಕು. ಅದ್ರ ಜೊತೆಗೇ ಲಾಸ್ಟ್ಲಿ ಎಲ್ಲ ದಾನಗಳಿಗಿಂತ ಮಹಾದಾನ ಸಮಾಧಾನ ಆದ್ರೂ ಅಂಗದಾನದ ಬಗ್ಗೆ ಇವತ್ತು ನಾವು ಬದುಕಿರಬೇಕಾದಾಗ ತುಂಬ ಮಾತಾಡ್ತೀವಿ. ಹ್ಯಾವ್ ಯು ಅಂಡರ್ಸ್ಟುಡ್ ಆರ್ಗನ್ ಡೊನೇಷನ್ ವೆಲ್, ಹೌ ಟು ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ಇಟ್ ಬೆಟರ್ ಆ್ಯಂಡ್ ಹೌ ಟು ಕಾಂಟ್ರಿಬ್ಯೂಟ್ ಬೆಟರ್? ಯಾಕೆಂದರೆ ಇವತ್ತಿಗೆ ಕರ್ನಾಟಕ ಈಸ್ ದ ಥರ್ಡ್ in terms of organ donations in the country. I was told by Dr. Gagan Brar herself that number 1 is Tamil Nadu and next to Telangana anta. So hingirbekadaga Karnataka is definitely a crown for IT and lot of innovations in the country, but why not healthcare and organ donation? So here I take the moment to welcome one and only nama Dr. Gagan Brar, lead consultant critical care, currently with Aster, but who's been around for more than 16 plus years, in addition to 10 years that she has spent to study medicine. So Gagan, ನಮಸ್ಕಾರ. ವೆಲ್ಕಮ್ ಟು ಜಸ್ಟ್ ಕ್ಯೂರಿಯಸ್ ಕನ್ನಡ. ಹೇಗಿದ್ದೀರಿ?
ಚೆನ್ನಾಗಿದ್ದೀನಿ. ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್ ಫಾರ್ ಹ್ಯಾವಿಂಗ್ ಮೀ ಹಿಯರ್ ಟುಡೇ.
ಪ್ಲೆಜರ್ ಇಸ್ ಆಲ್ವೇಸ್ ಮೈನ್. ಐ ಥಿಂಕ್ ಫಸ್ಟ್ ನಿಮ್ಮನ್ನು ವಿಚಾರಿಸ್ಕೋಬೇಕು. ಐ ಗೆಸ್ ಯಾವಾಗಲೂ ನೀವು ಪೇಷಂಟ್ಸನ್ನು ನೋಡೋದೇ ಕ್ರಿಟಿಕಲ್ ಕಂಡೀಷನ್ಸಲ್ಲಿ ಇದ್ದಾಗ, ಹೋಪನ್ನು ಕಳ್ಕೊಂಡಿರೋರಿಗೆ, ಭಯದಲ್ಲಿರೋರಿಗೆ ನೀವು ಯಾವಾಗಲೂ ಆ ಭಯ ಕೊಡ್ತಾ ಇರ್ತೀರಾ. ಸೊ ಫಸ್ಟ್ಲಿ ಐ ಥಿಂಕ್ ಐ ವಾಂಟ್ ಟು ಕೈಂಡ್ ಆಫ್ ರಿವರ್ಸ್ ಎಂಜಿನಿಯರ್ ದಿಸ್. ಫಸ್ಟ್ ಹೌ ಆರ್ ಯು ಅಂತ ಕೇಳೋರು ಇರಬೇಕಲ್ಲ.
ವೆರಿ ಕೈಂಡ್ ಆಫ್ ಯು. ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್ ರಶ್ಮಿ. ಐ ಥಿಂಕ್ very few people ask us this, but there are some kind families who always ask us, doctor, did you have lunch, did you have your breakfast? And so thank you very much for asking that. I am doing very well, thank you so much. and it's a pleasure to be here, and I'm so glad that I got this platform because your reach is like extremely good, and I want to reach to so many people so that they can understand what exactly what exactly we do in our everyday life in the ICU, what exactly we do when somebody is not doing very well, what exactly we do when some patient is crashing, and how we handle the patient as well as the distressed families, and how are we changing lives every day, saving lives when loss and life are bridging. So that is what we are going to talk about probably today. You have given me this platform to speak about all these things. Thank you so much.
Pleasure is always mine.
Yes, thank you.
ಅಂದರೆ ನಾನೇ ಒಂದು ಬ್ರಿಡ್ಜ್, ನಮ್ಮ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಇಸ್ ಅ ಬ್ರಿಡ್ಜ್ ಟು ಕನೆಕ್ಟ್ ದ ರೈಟ್ ಡಾಟ್ಸ್ so that those important dots of life
Yes,
can
yes.
probably come in handy for people who are in
You're
need.
doing a great service actually, like because this is a right platform where it is not it is through social media and the actual right people you're getting on your platform to talk about the actual things and not just misinformation, so which is
Absolutely.
very, very important in today's world, because so many misconceptions, so many fears, so many myths. So if those are coming from the direct person who is handling those things every
Right.
single day,
Credibility.
the credibility is different, and people understand it far better than just hearsay and somebody talking about it. So I think this is a wonderful platform to do all of that and
Sure.
sending the right message.
Absolutely. Ma'am, sure. Before I dive into what happens in an ICU, ಮತ್ತು ಯಾರು ಐ ಸಿ ಯುಗೆ ಎಲಿಜಿಬಲ್, ಐ ವಾಂಟ್ ಟು ಟಚ್ ಅಪ್ ಆನ್ ಬೇಸಿಕ್ಸ್. ಎಷ್ಟೊಂದು ಜನಕ್ಕೆ ಇವತ್ತು ಎಮರ್ಜೆನ್ಸಿ ಅಂತ ಸಿಚುವೇಶನ್ಸ್ ಕ್ರಿಯೇಟ್ ಆದರೆ ಅಲ್ಲೇ ಏನು ಮಾಡಬೇಕು ಗೊತ್ತಿಲ್ಲ.
Yes.
ಪ್ರಾಬ್ಲಿ ಫಸ್ಟ್ ಥಿಂಗ್ ಸಡನ್ ಬ್ರೆತ್ಲೆಸ್ನೆಸ್ ಬಂತಂದರೆ ಪ್ರಾಬ್ಲಿ ಕ್ಯಾನ್ ಐ ಸ್ಟಾರ್ಟ್ ಫ್ರಮ್ ದೇರ್?
Yes, please.
ವಾಟ್ ಶುಡ್ ಪೀಪಲ್ ಡೂ? ಹೌ ಶುಡ್ ವಿ ಆಲ್ ಬಿ ಮೋರ್ ಅವೇರ್ ಟು ಹ್ಯಾಂಡಲ್ ಅ ಸಿಚುವೇಶನ್ ಅರೌಂಡ್ ಅಸ್? ಬಿಕಾಸ್ ಇವತ್ತಿಗೆ ನೀವೇನೇ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಲಿ,
Yes.
ಎಲ್ಲರಿಗೂ ಕನ್ಸರ್ನ್ ಇದೆ. ಸುತ್ತಮುತ್ತ ನಿಂತ್ಕೊಂತೀವಿ, ಕೈ ಕಟ್ಕೊಂಡು ನೋಡ್ತಾ ಇರ್ತೀವಿ,
ಹೌದು.
ಅಥವಾ ವಿ ಡೂ ದ ರಾಂಗ್ ಫಸ್ಟ್ ಏಡ್.
Yes. So whenever patients ke, so for example consciousness illa or sudden collapse agide, sudden breathing difficulty ide, so first thing I always tell, call for help.
Meaning,
Always
call the hospital and
call the
ambulance.
hospital, call the ambulance. If it is next door, you just rush. If you think they are going to take time, you just take the patient and rush, because in our country the ambulances take a lot of time sometimes. So don't waste those precious minutes or waiting hours together for the ambulance. But of course, if you have no other person to help you, just call for the ambulance, wait, and do not, most important thing, do not put anything in their mouth. If for example, if somebody is breathless, don't give them water. If somebody is collapsing, please don't feed anything to their mouth, because everything, whatever you are doing at that point of time can impact. Person can choke on those things because they are not conscious enough to
Sorry.
even breathe. Say for example, we see a lot of families even in the ICU when they are breathless, right? They are, you and me for example, we are breathing right now. Are we realizing we are breathing? We are not even realizing, right? So what happens when somebody is breathless? Every single breath is becoming tiresome for them. Their whole concentration is on the breath, right? And at that point of time, if you start giving them water thinking that it will help, probably not.
Okay.
It will not help.
ಸೊ ನೀರು ಕುಡಿಸ್ಬೇಡಿ, ಏನೂ ತಿನ್ನಿಸ್ಬೇಡಿ.
No, a straight no. And what you must do, if you have anything in the house, some people, they may be using oxygen for old parents, some people they may be using oxygen concentrators, or they may be lying around during post COVID. Many people purchased those things,
Right.
so just connect oxygen for the time being if you have it, and
Sorry.
in the meantime of course call for help. And I have seen that sudden breathlessness is not as common as some signs and symptoms will always come before that.
Like
Collapse, yes, suddenly person collapsing, having a cardiac arrest, but breathing difficulty sometimes are, of course there are instances where it may come suddenly, like in some conditions, pulmonary there are a lot of medical conditions, but generally if it is due to infections, due to pneumonias, or even for example water filling in the lungs, so those things have certain things. If you notice, the person will not be feeling okay the first last 24 hours.
ಸಿಂಪ್ಟಮ್ಸ್
may be-
ಏನೇನ ಇಗ್ನೋರ್ ಮಾಡಬಾರ್ದು.
So sometimes you may be you see that breathing, right? It is not normal, right? It may start the previous day, especially old age. And in Bangalore, we see a lot of these respiratory tract infections
Because of the weather?
because of the weather and because of rising pollution, pollen, a lot of allergies. So we feel that, our atmosphere is much more cleaner than most, other cities. But still, the number of respiratory tract infections we see in Bangalore is our ICU at any point of time almost filled with half of the patients will be with respiratory tract infections.
How to save ourselves from that
So
situation?
what I have seen and what I tell my parents are old as well. So what I tell them, mask haki, best. Okay, protect yourself with masks whenever possible.
ಆವಾಗ ಆಚೆಗೆ ಹೋಗ್ತಾ
ಹೌದು,
ಇದ್ರು.
ಏನು ಪ್ರಾಬ್ಲಮ್ ಏನಿಲ್ಲ ಮಾಸ್ಕ್ಗೆ. ಓಕೆ, ಇಟ್ ವಿಲ್ ನಾಟ್ ಕಾಸ್ ಎನಿ ಪ್ರಾಬ್ಲಮ್ಸ್. ಇಟ್ ವಿಲ್ ಓನ್ಲಿ ಸೇವ್ ಯು. ಸೊ there is so much of pollution. Just wear a mask. You are going in the train, you are going in the bus, you are going for a walk downstairs. There is so much of breeze. Sometimes, you are unable to take that kind of breeze. And pollen, you will prevent pollen, you will prevent allergies. So I think that is the safest option. Just wear a mask. And it will really, really save you from plenty of problems.
Youngsters watching this from 40 to 60, ಅವ್ರಿಗೂ ಇದು ಅವಶ್ಯಕತೆ ಇದೆಯಾ?
ಹೌದು, ಇದೆ.
Even
But of course, if you are in the background, you are very healthy. See, it's not like we are seeing pneumonias only in old people. We are seeing very severe pneumonias even in younger age groups.
Oh.
Yeah, because see, most people are, young people, their physiology is much better than older age groups. But of course, there are nowadays lifestyle diseases, for example, diabetes, right? Hypertension. So a lot of these lifestyle diseases are creeping in, into our society. So what is happening? These people are also at risk of getting all these infections which we think were only happening during old age. Smoking history, pollution, workplaces like that where there is so much of smoke inhalation. Vaping, oh my God, let's not even go there. And it's not style, it is just death waiting.
Could you please throw more light? Yakandre, since we have touched that branch, and probably we can
we feel, see, I'll tell you something about addictions, right? Or even for pleasure, what people do in our day-to-day things. When you drink alcohol, most of the times people sit in the evenings and probably start drinking after 7 o'clock, 8 o'clock. They may have few drinks, most of the people. But with smoking and vaping, the things are, you can do this anytime, anywhere. And people, you understand what I'm trying to say? You don't have to, sit at one place. Yes, just 2-3 minutes, 5 minutes. People
vaping
just
even worse adu.
Worse.
ಎಲ್ಲೆಲ್ಲಿ ಕೂತಿರ್ತಾರೋ ಅಲ್ಲೇ ಶುರು ಮಾಡ್ತಾರೆ.
Exactly. And it seems there have been studies which are linked to irreversible lung damage due to vaping.
I read about popcorn lungs one.
Yes.
Can you warn our youngsters today? Yakandre, it is a very handy little toy which is all flavored, and people are not realizing the damage that can do.
It can kill you in no time. And there is nothing you can do about it going back. There's nothing. It's
irreversible damage.
Yes, irreversible damage. And as I said, each breath becomes a work. Right now, what we are taking it as luxury. Like, we are just thinking, what will happen? Or some people think, I will stop tomorrow. This is only for today. That tomorrow never comes. Whatever has to happen, it has to happen today. If you are thinking of stopping something, you have to stop it today. And it not only kills your lungs, it kills all your blood vessels. Okay, it ages your skin. It does a lot of more damage than just lungs. So hypertension, right? It shrinks your blood vessels. So all those things are smoking, vaping. These are now just different things. People are going into much more, drugs other than these common ones. People are getting into coke and marijuana, and they think marijuana is very cool and very safe. It's not like that. Everything has its own problems.
What are the effects of coke and marijuana? And
See, we see a lot of drug overdosages, right? Suddenly your blood vessels shrink and your blood pressure can increase suddenly, and people can have intracerebral hemorrhage, bleeds. in the brain, yes, they can suddenly become brain dead with that bleed, because they are youngsters. They don't even have space in the brain. Their brain is like full size. It
This
is
is
not
what
like
the side effects of coke and
yes,
marijuana.
marijuana no, but coke, yes, we have seen multiple times.
But
Marijuana,
even
I think with age, the the brain capabilities and your cognitive function, I'm sure it's gonna affect it, and probably it affects the neurons, and it affects your many more abilities. So you feel that you feel good for some time, but that is ultimately not the goal, right? You should feel good even when you're 80, if you're alive, of course, till then. But yeah.
I'm touching these uncomfortable topics, but which are definitely the need of the hour.
Yes,
So
definitely.
ಇವತ್ತು marijuana ಅಥವಾ ಇನ್ ಗಾಂಜಾ ಅಂತ ಮಾತಾಡ್ತೀವಿ. Lot of them look at it as medicinally ಒಳ್ಳೆದು ಅಂತಲ್ಲ advice.
If it is advised by a doctor in a limited quantity, in a different form, that is medicine. Not like what you are smoking every day, thinking that it is something, recreational drugs, as we call it. It should not be part and parcel of your everyday life.
Have you seen any case wherein cognitive function ಪರ್ಮನೆಂಟ್ ಆಗಿ ಈ ಡ್ರಗ್ಸ್ ಎಲ್ಲ ಯಾವ ರೀತಿ ಡ್ಯಾಮೇಜ್ ಮಾಡುತ್ತೆ? ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಗಾಂಜಾ ಆಗಿರಲಿ, ವಿ ಆಲ್ ನೋ ದ್ಯಾಟ್ ಅದನ್ನ ಇವೆಂಚುಲಿ ಸ್ಲೋ ಮಾಡಿಬಿಡುತ್ತೆ ಪರ್ಸನ್ ಅನ್ನ ಅಂತ.
To be honest, I know a few people whom they are our friends, have been smoking for a very long time, and you can tell the difference. That sometimes I just joke around like he's not making any sense, and they just keep talking, and probably I think sometimes they even can't relate to what they are talking. I think, and they have been doing all these things probably from last 10 years or 15 years, and even coke does the same to you. Like you are not normal. After doing that, you become suddenly hyper, and all this energy comes in, and then you can tell in 2 minutes that somebody is not normal. So I will not say that I have treated many, because ours is not a psychiatric hospital, or even ICU. We generally see drug overdoses.
ನೋಡ್ತಿರಲ್ಲ?
Yes. So, but not in the long-term effects, I would say. Those things, I think psychiatrists are better people to see the
Advise and comment. Yep.
long-term effects of those, because they are seeing those people.
ಹೌದು. ಸೊ ಡ್ರಗ್ ಓವರ್ಡೋಸ್
Or neurologists, they may be seeing those people more over a period of time.
ಐ ಆಮ್ ಶೋರ್. ಸಿನ್ಸ್ ವಿ ಆರ್ ಟಚಿಂಗ್ ಕ್ರಿಟಿಕಲ್ ಕೇರ್,
Yes.
ಡ್ರಗ್ ಓವರ್ಡೋಸ್ ಅಲ್ಲಿರೋರಿಗೆ ನಾವು ಫಸ್ಟ್ ಏಡ್ ಹೆಂಗೆ ಕೊಡಬೇಕು?
First of all, as I said, if somebody is unconscious, please do not attempt to put anything in their mouth, and call for help as early as possible. Yes, feel for pulse if you can. Otherwise, if you feel that somebody is not breathing, you just start bystander CPR.
ಹಂಗಂದ್ರೆ
Just start chest compressions. You just need to make the patient flat, and you just start pumping their chest. Okay,
ಎಷ್ಟ್ ಸತಿ?
so 100 to 120 times per minute, and just keep counting. You don't need to do those mouth to mouth breathing and all that. All that is not needed.
This area?
Just this
Center
area,
area.
center of the chest. Just start chest compressions, as we call it, and wait for the ambulance. If you feel that somebody is not breathing, somebody probably doesn't have any blood pressure or pulse, suddenly collapsed, that is the best thing you can do for anybody. Don't.
ಹಂಗೆ ಮಾಡ್ತಾ ಇದ್ದಾಗ ಏನಾಗುತ್ತೆ? When you do
So
CPR?
yes. So what happens? See, what we are suspecting here is probably the heart is not pumping blood to any organ, because what happens when your heart is pumping blood, right? That is when the blood flow goes to the brain.
And
When the brain
takes
gets
the function.
oxygen, right? So when you do this, you are basically trying to preserve all the organs. When you are trying to do this, in the meantime, till the help arrives. So you are giving chest compressions, you are making sure that the brain doesn't get, because brain can get damaged within 5 to 7 minutes, permanently damaged, if the help does not arrive because of lack of oxygen.
ಕನೆಕ್ಷನ್ ಕಟ್ ಆಗ್ಬಿಡುತ್ತೆ.
Howdu full cut agbiಡುತ್ತೆ. So what happens is permanent brain damage due to hypoxia. So this is the only chance which can you can give to the other person who is just lying there in front of you, and you don't feel helpless. So in the meantime, call for help, because I don't think anybody can do anything more than this in their homes. So I always feel that bring them to hospital as early as possible. That is the only chance at saving their life.
What are mistakes people do before they get the patient to the hospital?
Yeah, so sometimes I feel even if they're seeing that they're not doing well, they wait too long to ask for help. They wait too long, right? Example, like for example, somebody's not feeling well from last night, have been saying that I think I'm feeling chest discomfort, but it could be, I had a heavy meal,
Acidity.
right? Very common. In fact, so common, you'll be surprised with that, and then suddenly patient is found with no life the next day when you open the door, and when you see that why he or she is not waking up. So don't delay those. You can come and get checked, could be wrong, but it is much more safer than not entering the hospital fearing that they may do unnecessary tests, or I may have to they may just get to know with simple blood test, with simple ECG or a simple echo. You may not even need to undergo any of the other tests, but at least you'll be at peace of mind. So, and we can really see that whether it is actually related to heart or related to other things. So this is just one basic example, so there are other things as well. As I said,
choosing
if you
the right
have
hospital, nursing home,
that is where people feel scared that whether they are going to. But for me, I feel in emergencies, don't look for the best of the best. You can go there once the things are stable. If you're in real emergency, go to the nearest decent nursing home. They will do the basics. In India, we are lucky. If you wherever you reach, they will do the basic. Yes, how do. At least if airway is not protected, what I mean by airway is not protected. So as I was talking, right, people, they keep on feeding water. So what will happen when you are not conscious? You can't swallow. You may just you may be coughing if you're mildly conscious, or you may not be even doing that. People may be putting water, and everything which is supposed to go into your food pipe and stomach, it is entering your lungs. So there are two pipes here, right? The windpipe, the trachea, and the food pipe. So it is all entering the wrong pipe. So you are basically drowning them in water. When you think that you are trying to help them by, that is the first thing they bring. Give him some water, sit him up, give him. Maximum you can do is lift their legs up, probably, if it is just a syncope. Syncope means just sometimes you feel giddy and you fall, right?
So kalini ketbeko.
How do? So blood pressure improve agtade. Yes. So suddenly somebody was doing well, suddenly feeling giddy, and you don't have to start chest compressions there. You just wait for some time and see if chest is even moving. If they are breathing, just lift their legs up, and brain will get the blood flow, and they will wake up.
Ulta wapas venous.
How do? Venous return. You know so much of medicine.
No. All thanks to people like you all sitting here and educating us. So adu ulta adu.
Yes. And sometimes if seizures are happening, say somebody is having fits, right? So again, don't feed them anything or don't put anything. Just put them on the side position, right? Just bit of lateral position, and just hold them there and call for ambulance. Generally, those fits slowly, gradually fade away. Sometimes it can continue for 20 minutes, 25 minutes, but by then you would always reach a hospital.
So hale kaladalli kabana kododu, key kodadella ivatgu work agata athwa it
doesn't work that way. You don't need to do any of those.
So left ga right ga
any lateral position is fine.
What happens when you do that?
So you're trying to again prevent the airway. You're so that whole of saliva and froth and everything is not directly entering your lungs and not choking you, right? The idea is to so that the person does not choke on its own secretions, so that the person continues to breathe properly, and some oxygen should reach the brain, and even if it drops, but at least even if up to 75-80 you are okay with that kind of saturation. So we are just trying to at that point of time, whatever is best possible, we are trying to do. We cannot do everything at home, we cannot do everything on the road, but these are the things which we can do.
SOS.
Yes, to prevent further damage. One injury has already happened. Let's not make it worse by causing more injuries.
Contain it.
Yes. How do?
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ರಾಧಾ ಬೈ ರ್ಯಾಪಿಡ್ ರಶ್ಮಿ. ಇದು ಒಂದು ಎಥ್ನಿಕ್ ಸ್ಟುಡಿಯೋ. ವೆಬ್ಸೈಟ್ ಅಲ್ಲಿ ಇರುವಂತ ಎಲ್ಲಾ ಒಂದು ಕಲೆಕ್ಷನ್ಸ್ ನಾನು ಕ್ಯೂರೇಟ್ ಮಾಡಿರುವಂತ ಇಟ್ ಇಸ್ ಮೈ ಸ್ಟೈಲ್ ಸ್ಟೇಟ್ಮೆಂಟ್ ದೇರ್ ಇಸ್ ಸಮಥಿಂಗ್ ದಟ್ ರಿಫ್ಲೆಕ್ಟ್ಸ್ ಯು. ನಿಮ್ಮ ರಾಧಾ ವೆಬ್ಸೈಟ್ ಲೈವ್ ಆಗಿದೆ, ಖಂಡಿತ ಹೋಗಿ ಎಕ್ಸ್ಪ್ಲೋರ್ ಮಾಡಿ. ಇದೊಂದು ಸ್ವಲ್ಪ ಔಟ್ ಆಫ್ ಸಿಲೆಬಸ್ ಇರ್ಬೋದು, ಬಟ್ ಔಟ್ ಆಫ್
ಪರವಾಗಿಲ್ಲ.
ಕ್ಯೂರಿಯಾಸಿಟಿ ಐ ಆಮ್
Yes,
ಆಸ್ಕಿಂಗ್
please.
ದ್ಯಾಟ್.
Go ahead.
ಈ ಫಿಟ್ಸ್ ಎಲ್ಲ ಬಂದಾಗ, ಸೀಜರ್ಸ್ ಬಂದಾಗ ಬಾಯಲ್ಲಿ ನೊರೆ ಬರುತ್ತಲ್ಲ,
Yes.
ಆ ನೊರೆ ಏನಕ್ಕೆ ಡಾಕ್ಟರ್?
It is just your normal saliva. That's all. Yeah, because you are just, shaking and, so it just kind of, it's nothing like, sometimes your stomach contents can come out. That will be vomitus. But generally it is all froth. Because we produce so much of saliva every day. Almost, a liter of saliva every day.
ನಾವು ಒಂದಿಸಲ್ಲಿ 1 ಲೀಟರ್ ಎಂಜಲು ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತೀವ.
Yes. Maybe more.
ತುಂಬ
I'm
ನುಂಗ್ಕೊಂತೀವಲ್ಲ,
forgetting,
ಗೊತ್ತಾಗಲ್ಲ.
the exact numbers, yes. So
Amazing. Thanks for educating
Yes.
us. The last in the
human
list
body
is
is excellent, unless we really damage it, it always tries to save us.
ಅದ್ರ ಪಾಡಿಗೆ ಅದು
Human body has very good resilience, if you see that. The kind of recoveries what we see in our everyday ICU, you will be amazed at what our body can do.
like, what has surprised you the most? An
Like,
example.
for example, you look at these strokes and, traumatic brain injuries, like after trauma, if you see people, when you see them on day 1, post-trauma, you will be like, will he ever wake up? And after 6 months, they are walking into your ICU back to see you. Right? So that is the importance of getting proper care in the beginning. That is the importance of getting, as you said, the first aid plus immediate after the first injury, how to prevent the other injuries and what to do best for our body to recover properly from any injury, for that matter, any organ. Because there are 5 important organs in the body, which is brain, heart, lungs, kidneys, liver. We call them end organs. If one gets affected, rest 4 will not survive.
Oh,
Yes.
brain, heart, lungs, kidney, liver.
Yes. So these are the 5 end organs. They will ultimately always affect the other 4, somehow or the other.
ಇವರೆಲ್ಲ ಗುಂಪು.
Howdo? It's like all connected. All are pathways to each other. For example, I'll give you a very small example. If your liver fails, if somebody's liver fails, right? I'm sure a lot of people are nowadays even dealing with fatty liver and all those lifestyle problems. Youngsters, right? So from outside they'll be looking so thin, and from inside their whole liver is full of fat. So, for example, I was just telling you about liver. We get a lot of liver patients in our ICU. So what happens is, once your liver is affected and it reaches a stage where it is not functioning properly at all, what happens next is your kidneys start failing. Your brain is getting those toxins and you are becoming drowsy. The patient is becoming drowsy. We call it encephalopathy. Okay.
Encephalopathy.
Yes. So they're completely delirious. And when the family says, what is happening? Kidneys, your creatinine levels are rising. It is a renal function test which you check to check your urea creatinine levels. I'm sure most people would have heard of it. Then your brain doesn't work properly. Your lungs get filled with water. Your abdomen gets filled with water. And with all this, ultimately your heart can get affected. So one organ, if out of these does not work properly, the other 4 are likely to suffer at some point of time.
Now that you've given us the 5 main organs, I'm going to reverse engineer it again. ICUಗೆ ಬರದೇ ಇರೋ ಥರ ನನ್ನನ್ನು ನೋಡ್ಕೊಬೇಕಂದ್ರೆ ಪ್ರತಿಯೊಂದು ಆರ್ಗನ್ ಹೇಳ್ತೀನಿ, ಹೌ ಐ ಶುಡ್ ಟೇಕ್ ಕೇರ್ ಆಫ್ ದಟ್ ಆರ್ಗನ್, ವಾಟ್ ಐ ಶುಡ್ ಬಿ ಡೂಯಿಂಗ್ ಅಂತ ನಂಗೆ ಹೇಳಿ ಆಯ್ತಾ. ಫಸ್ಟ್ ಐ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ವಿತ್ ಲಿವರ್ ಓನ್ಲಿ. ಬಿಕಾಸ್ ಇವತ್ತಿಗೆ ತುಂಬಾ ಯಂಗ್ಸ್ಟರ್ಸ್ ಫ್ಯಾಟಿ ಲಿವರ್ ಅಂತೆಲ್ಲ ಇದು ಮಾಡ್ತಾರೆ.
See, I would really request everyone to first of all stop eating outside so much. We don't need so much of outside food. Let me be very honest with you.
It's
okay.
like a slap on my face right now.
Yeah, we do not need, because if you see them cooking, you will probably never enter any restaurant again, because the amount of oil they use. Do we really need that much of oil? In my house, both my parents are actually cardiac patients, okay, because nobody had awareness even those days, right, when we were growing up. So both my parents have what we call it coronary artery disease, so where you get plaques in the coronaries, right? But they are okay. They are otherwise okay. You will not know if you see them. They are old, frail, but otherwise okay. So what happens is, when you see those people, the amount of oil. So at my house, we don't use any oil. We just do cooking in water.
Oilless cooking ಮಾಡ್ತೀರಾ?
Yes, completely because of them. Like,
so
when
it works?
it work. You will not know if I give you food today. You will not know if the food has oil or not. You will not be able to tell me. So the amount of oil which people are using, it is absolutely not required. In fact, so many apps are there which tell you to quantify and take everyday oil.
Example?
Like for example, I shouldn't be taking names, but
You can help us. It's
okay,
fine.
Fitter, like it's one of the apps which will tell you how much quantity of each oil, carbs, it's like quantified nutrition. So
Like Healthify me.
I don't know if yes,
maybe ನೀವು ತಿನ್ನೋ ಕ್ಯಾಲರೀಸ್ ಅನ್ನ ಕೌಂಟ್
that is only that, but here they teach you as well about nutrition. Fitter, yes.
Nice.
So it's a very good app actually, and it has a lot of free this thing. You don't have to really subscribe to it. It will just tell you based on your body weight, based on your age, based on your other metabolic parameters, do you really need this much of oil? So you have to and carbs, like refined carbs. Do not eat too much of processed food. I'm not saying you stop everything. You must enjoy life. Life is to enjoy, right? So but everything in moderation. Moderation is the key. You want to eat out, you choose a place and choose something little bit more healthier than your normal options, so that will make a lifestyle modification for you. And after, if you follow it for 3 months, believe me, you will not look at oil, because then you will start feeling that, oh, what am I eating? So for me, I think I too eat out, but not like every single day. You can do probably once a week in a very conscious manner. And whenever you're eating, do not eat as they say up to full, till you're full. Yes, up to
like Japanese also they
yes,
follow, right?
yes. You eat 80%. Then you wait. If you're hungry, still after 20 minutes, go ahead and eat. So all these drugs, what they are doing is also doing the same thing, right? They are trying to suppress your hunger. They are trying to suppress they're trying to make you eat less. But we cannot sustain that for a very long time. In the beginning, yes, it is helpful for very helpful for those people who are really obese and unable to do anything until now, the food noise as they call it. So those things are good. But so as we were talking about, I'll come back to liver. So these are the basic things: processed foods, too much eating out, too much of oil, and zero activity. Zero activity. Imagine we take care of our cars so much, we take care of everything so much, but we don't have 20 minutes for our own body. So just a simple walk. Your whole healthy lifestyle is just a walk away. Like, you just walk for 20 minutes. You eat, just walk. You are talking on the phone, you walk. Makes a lot of difference. And you will start feeling movement. We were meant for movement. We were not meant to sit inside the rooms, and we were not those indoor people, evolution wise as well, right? So I think we should probably try, like 5 minutes. You can't give 20 minutes, try for 5 minutes. If you start somewhere, you will reach there.
Many ways to do it.
Yes.
Like my favorite is I have my walking pad. ಯಾವುದೋ ಟಿವಿ ಸೀರೀಸ್ ನೋಡ್ಬೇಕಾದ್ರೂ ಅದನ್ನ ಆನ್ ಮಾಡ್ಕೊಂಡು
I do that. I watch Netflix just to relax in the night. Everybody watches it. So sometimes I just don't sit on the sofa. I just walk in the I sometimes laugh. In the ICU I used to walk. There was many years ago, and my senior boss, like those who my HOD, he used to laugh at me and say, Gagan, this is crawling, this is not going to help you. Like I still laugh at that. So but I think crawling is okay than not doing anything. Crawling means like when you walk really really slow and you are not, people feel, but that is also movement. Do something, right?
Yeah, nothing. Yeah.
So yeah.
So good. That's for the liver. No outside food. Control oil if possible. No oil cooking.
Yes.
Zero activity is a big no.
Processed foods, unnecessary sugar. See, sugar itself is not too bad, I would say. You can take a little bit of sugar. Not going to die with that. But don't eat sweets every day. Don't eat ice creams every day. Have it when you feel like. Or even when you're having it, have little. So we have to live. We should not stop living. We should enjoy those, nice things in life, right? What is life about if we can't even eat those things? But everything in moderation. So if you look around us, there are so many obese people around you, and you feel that, like, just do something about it. Like, So it is not only about appearance. It is not only
Genes.
about, genes. I think the obesity part is not only genes. I think this all we have brought on upon ourselves, most of it. So genes, we always try to put it on genes, especially this part of it. There are many diseases which are genetics. We cannot do anything about it. But there are things which we can modify and probably delay it.
Mm-hmm.
Right. So for example, diabetes, if somebody in genetics, nowadays they're saying that it is completely reversible if you take care of yourself, but still, if somebody has it, in spite of all the healthy living, people are getting it. So even if it's genetics, probably you can delay it, or you can delay the complications of that disease. Your end organ damages you can reduce if you keep your sugars in check.
Right.
So those are the things we are looking at.
Next is kidney. Kidneyನ ಕಾಪಾಡ್ಕೊಬೇಕಂದ್ರೆ 3 things to do.
3 things to do. I think once you reach a certain age, just get your baseline renal function test. Probably.
Certain age.
A certain age means when you are 30, 25, 30. Yeah.
25, 30.
Yes, better to get one done.
Baseline?
Renal function test, which is urea creatinine. And of course, whenever you're having, very important, what people we get within our ICU, they always underestimate how much less fluid they are drinking. They always, they can never imagine that how much less liquids they are taking. I'm talking especially when they're not well, when they have fever, when they have infection, or when they have loose motions, right? Loose stools, GI infections. So what happens, people must be passing every hour stools, but they are unable to hydrate themselves that much. So we get people on those who land up on dialysis with so much of severe kidney failure, because we call it acute kidney injury in ICU, that it has happened due to an acute event, and the creatinine has gone up, urine output has dropped, acid levels have built up in the body. So those are the things which you should be aware of, that these are not minor things. When you are unable to even eat and drink, go to a hospital early, get an IV fluid, get administered with an IV fluid. That will really help you save your kidneys. And check your blood pressure, once again you are reaching the age of 25, 30, at least once a year, and then once every 3 to 6 months. It is a very simple thing, but please do that. It's extremely important.
BP and kidney.
Yes, so they're all interconnected.
Right.
If your kidneys are not functioning, probably could be some kidney issue from the beginning, from childhood, which goes unnoticed, or genetic disease as we call it, right? So it may start increasing your blood pressure, or it could be the other way around. Your blood pressure can lead to your kidney failure.
Wake up to fresh ideas. Repose.
So people, those who have unrecognized hypertension and keeps on going on for years and years together, we see them at a stage where their creatinine is 5 or 10 and their blood pressure is 250.
Sorry now to bring this urea and creatinine here.
Yes.
ಇದ್ರದ್ದು ಕಿಡ್ನಿನಲ್ಲಿ ಇದ್ರ ಎರಡರದ್ದು ರೋಲ್ ಏನು?
So it is, if you don't have kidneys, you cannot live for long. Basically all your toxins, all your bad materials in the body, it is working. Yes, everything it is clearing.
Sorry.
So if you are unable to do that, imagine the amount of toxin buildup happening in your body, and what will happen to your fluid, whatever you are drinking. See, whatever food you are eating is 80% water, whether you're eating solids or you're drinking. Imagine the amount of bloat up will happen if your kidneys are not functioning properly. Imagine your potassium levels, all those electrolytes, what is happening in the body, your sodium, potassium levels, your calcium, magnesium, all these electrolytes are managed by this powerhouse, kidneys.
So ಇಲ್ಲಿ ಯೂರಿಯಾ ಮತ್ತೆ ಕ್ರಿಯಾಟಿನಿನ್ ಲೆವೆಲ್ಸು ಅದೇನು ಇಂಡಿಕೇಟ್ ಮಾಡುತ್ತೆ ಬಾಡಿನಲ್ಲಿ?
So if your urea is going high with your normal creatinine, that means simple dehydration, or some other small things. But if your creatinine and urea are high, creatinine is it's an indicator that your kidneys are not functioning well. So normal is up to 1.2 based on each lab, right? So 0.5 to 1.2. So based on each lab, what is the highest they're giving. So if your levels are even slightly higher, you must get yourself checked. Go to a nephrologist, get yourself checked. What is going on? do not ignore it.
ಸುಮ್ಮನೆ ಹೋಗ್ಬಿಡತ್ತೆ ಅಂತ ನೀರು
Yes,
ಕುಡಿಯೋದು
yeah,
ಎಳ್ನೀರು
just take
ಕುಡಿಯೋದು
water, creatinine. No, it won't. And people taking all kinds of supplements, all these protein powders without knowing what exactly goes inside them. Seeing so many cases actually of liver failure, kidney failure with all these things,
supplements, not just
which
protein,
are not
even
just
other tabs.
oh my god, I can't take the brand names, but we have had so many of liver failure cases because of the person has taken it for 6 months as a well-being and weight loss and normal naturopathy kind of thing. So they just came with pneumonia and in the meantime found to have bad liver functions along with continuous recovered from all that, but the liver never improved. So ruling out in fact everything else. So, and it is not only one-off case, I'm talking multiple cases.
ಸೊ ಸಪ್ಲಿಮೆಂಟ್ಸ್ ಅಂತ ಬಂದಾಗ ಇವಾಗ ಏನಾಗ್ಬಿಡಿದೆ, ಇಟ್ ಇಸ್ ಬಿಕಮ್ ಲೈಕ್ ಒನ್ ಟಾಫಿ ಟುಡೇ.
You know why? Because we don't have strict control. Whatever we are getting today, have you seen the quality of those things? What we get today and what
ಫುಡ್
yes, and what other countries get today? Like the same brand, the same everything they are doing. People are getting so aware, they are doing testing on all those brands and they are coming up with all those things which in our own hearts probably we would have known, but when it is in front of you, you feel okay, what I was thinking was right. You must read labels, but I think even after labels, it's much worse than that because there is no control, right?
ಹೌ ಟು ಟ್ರಸ್ಟ್ ದ ಲೇಬಲ್ ಇಸ್ ಅನ್
How to trust the label.
ಸೊ ಸಪ್ಲಿಮೆಂಟ್ಸ್ ಅಂತ ಬಂದಾಗ ಫಾರ್ ಜೆನೆರಿಕ್ ಅಡ್ವೈಸ್
Yes.
ಈಗ
See,
ಒಮೆಗಾ ಇದೆ,
do not, yeah, those things, yes, those are good. Those things are good. Those supplements are good. I'm not talking about those supplements. I'm
Yavudu
talking
should
about
be watchful.
those, those protein powders and all. Okay, supplements, if you're a vegetarian especially, and if you don't have good omega-3s, you must take those. Those are good. But take from good brands, not just random.
like what do you watch for?
I will not vouch for anything. But yeah, a lot of good brands, like, good companies.
ಸರಿ.
Then you have vitamin B12, as you said. Most of the times the absorption doesn't happen. Like, even if even people who are eating non-veg also, sometimes B12 can be less. Vegetarians, they are really, really, have less B12 level. Vitamin D. Look at my God, it's like all over the country. Everyone is has deficit in vitamin D levels, right? So I think we must supplement vitamin D as well. And it's not only you stand in the sun and you will get, you must see, like, some people, especially they say our skin does not let us make so much of vitamin D as the white skin.
Oh,
Yeah. So
ಅಂದ್ರೆ ನಮ್ದು
the sun,
absorption ಕಮ್ಮಿ.
yes. So even so you can take good supplements for vitamin D, like every week some 60,000 units, or and check your vitamin D levels at least once in 6 months to 1 year. So that will help you guide and see your specialist physician to help you guide into all those things.
ಸೊ ಕಿಡ್ನಿ ಬೇಸ್ ಲೈನ್ ಫಂಕ್ಷನ್, ಬಿ ಪಿ ಚೆಕ್ ಮಾಡಿಸಿ ಸಪ್ಲಿಮೆಂಟ್ಸ್ ಮೇಲೆ
Be careful what you're putting inside your body. That's all. You can take so much of protein from natural resources,
your favorites being?
To be honest, I am a non-vegetarian, so for me it's really not a problem. But you can, as I said, you can quantify, you can weigh. In each thing you can know how much. If you just Google it, you will know how much uncooked dal contains, or paneer contains, or how much all these things contain, how much protein. So you can make your whole diet chart around that.
ಸರಿ. ಮುಂದಿಂದು ಲಂಗ್ಸ್ ಕೈ ಕೊಡಬಾರ್ದಂದ್ರೆ, ಎಮರ್ಜೆನ್ಸಿಗೆ ನಮ್ಮನ್ನು ಕರ್ಕೊಂಡು ಹೋಗ್ಬಾರ್ದಂದ್ರೆ ಏನು ಮಾಡ್ಬೇಕು? ನಾನು 3 things to do.
So first of all, as I said, if somebody is really having trouble in breathing, you must immediately bring them to the hospital without second thought. I think everyone will do that. That is, without. Second is, as I said, protect it. Quit smoking. Quit all these vaping, quit all the things, like you don't need them, like so you can really end pollution. Yes, wear masks.
ಸೊ ಈಗ
Very important.
And also ಈ ಪ್ರಾಣಾಯಾಮ,
Of
ಭಸ್ತ್ರಿಕಾ.
course, it all helps. It strengthens your lungs. Incentive spirometry we give to all our ICU patients.
What's that?
Also, you would have seen a device where there are 3 balls, red, yellow, green.
Oh,
Yeah, so you tell them to blow inside. So
red, yellow, green.
yes, I think so, or white probably. So
Sorry?
when they blow inside, so you have to make sure that at least 1 or 2 balls go up. So that means you are taking breathing air in. When you're breathing in, you do that, those balls go up. So you know that, okay, how much
Function
yes, you are able to. The more you are able to do all the 3, you are excellent. So in the beginning they may not be able to even do one completely, those who are recovering from these lung infections or some weaknesses, but gradually we make them do every day, every 2 hours, every 3 hours.
So you can increase your capacity alva?
Yes. So post COVID, yes, people have been doing it. People are really taking care of themselves, and this is the main thing which you must do, or you should do, as you said, deep breathing in the morning, 5 minutes. It doesn't take long. So just give some 20-25 minutes to yourself and you're sorted.
ಮೈಂಡ್ಗೂ ಅಷ್ಟೇ, ಲಂಗ್ಸ್
You just need to probably bring in discipline. That's all. We all lack that at some, because so much is going on in life, right? So much stress, so much of so many things going on in mind, and you always feel that I can do it tomorrow. But today is what we have. Nobody has seen tomorrow. So,
Well
but
said.
then they will say that why should we even exercise when we have not seen tomorrow? But yes, but what we have today, we should live healthy.
The next is the heart, of course.
Yes. Again, all these things are connected. You take care of your diet, your lifestyle, exercise, your cardio, strength training. You take walks. You just sometimes in spite of doing all this, genetics wins. Okay, you can, but you will be able to deal better with those things. If even if you have certain things, you may be able to. We see healthy people dropping dead. We have seen 18-year-olds, 20-year-olds dropping dead. So see, those are rare things. Let us not completely rare, but yeah, those things are less than definitely people suffering from coronary artery disease or the chronic diseases, or then going into heart failure. So that is one spectrum of things. This is another. So don't just look at, oh, he was exercising and he too died, or he was doing too much. Too much is bad too, right? So everything in moderation.
ಕೊನೆಯದಾಗಿ ಬ್ರೈನ್. ಸೊ ಐ ಸಿ ಯುಗೆ ಬರದೆ ನಮ್ಮ ಬ್ರೈನನ್ನು ನಾವು ಕಾಪಾಡ್ಕೊಬೇಕಂದ್ರೆ, ಲೈಕ್ ಬ್ರೈನ್ ಅಂದ ತಕ್ಷಣ ಬರೋದೇ ಇಲ್ಲ ಹೆಮರೇಜು ಇಲ್ಲ ಸ್ಟ್ರೋಕ್ ಅಂತ.
Yes, so brain gets affected due to various reasons, right? Like the direct brain injuries, which, as you said, strokes and traumatic trauma, right? Or due to any other reason like post cardiac arrest, damage to the brain. There is no, patient is not conscious enough, in a coma. So all those things. And then there are secondary causes like illness is in some other organ, but the patient is not, patient is delirious, cognitive dysfunction, memory loss. So all those things we see in intensive care. In fact, many patients who are geriatric age group or old age group. So we see when they're coming out of illnesses, many of them become delirious.
ಡೆಲಿರಿಯಸ್ ಅಂದರೆ
Delirious is like they are not oriented to space, person. If they see their family members, they get, of course, they start, and otherwise it's unfamiliar setting.
ಆ ಥರ
There-
ಸ್ಥಿತಿಗೆ ಯಾಕೆ ಹೋಗೋದು ಯೂಶಲಿ?
So it is due to various reasons. First and foremost is the disease itself. How severe the disease was, the baseline disease, what they were admitted with, how long have they been in the ICU, how was their baseline acuity, how were they,
ಬೇಸ್ಲೈನ್ ಅಂದರೆ
baseline means how were they prior to this episode, right? Because sometimes even small things like dementia may be setting in, but they may not be even realizing. So those things make it worse with age. So it depends on each condition what they present with.
ನಾವು ಐ ಥಿಂಕ್ ಬ್ರೈನ್ ಬಗ್ಗೆ ಮಾತಾಡ್ತಾ ಕೋಮಾ ಆ್ಯಂಡ್ ಐ ಸಿ ಯು, ಇಟ್ಸ್ ಲೈಕ್ ವೆರಿ ಕನೆಕ್ಟೆಡ್ ಟಾಪಿಕ್ಸ್ ಅಲ್ವಾ? ಪೀಪಲ್ ವಾಚಿಂಗ್ ದಿಸ್, ನಮ್ಮ ಜನಗಳಿಗೆ ಕೋಮಾ ಬಗ್ಗೆ ಕರೆಕ್ಟಾಗಿರೋ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್ ಇದೆಯಾ? ವಾಟ್ ಇಸ್ ಕೋಮಾ ಬೇಸಿಕ್ಲಿ, ಆ್ಯಂಡ್ ವೈ ಇಸ್ ದ್ಯಾಟ್ ಕೋಮಾಗೆ ಹೋಗ್ಬಿಟ್ರೆ ಯೂಶಲಿ ದರ್ಸ್ ಅ ಬಿಲೀಫ್ ಅಲ್ಲಿಗೆ ಹೋದರೆ ಇನ್ನು ಅರ್ಧಕ್ಕರ್ಧ ಆಲ್ಮೋಸ್ಟ್ 70% ಕೇಸ್ ಕ್ಲೋಸ್ ಅಂತ. ಸೊ ಇವೆಲ್ಲ ಮಿತ್ಸಾ? ಇಸ್ ದೇರ್ ಸಮ್ ಟ್ರೂತ್ ಟು ಇಟ್? ವಾಟ್ ಇಸ್ ಇಟ್? ಹೌ ಶುಡ್ ವಿ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ಇಟ್?
So When you talk about coma, we have to understand why it has happened, why the coma has happened. Coma means patient is unconscious. Patient is not himself or herself, not into their senses. When you try to wake them up, they don't respond.
ಯಾಕೆ ಕೋಮಾಗೆ ಹೋಗೋದು ಯೂಶಲಿ?
So that's what various reasons for
Reasons.
that, as we most of it related to brain. So could be stroke, could be any traumatic brain injury like post trauma, could be, as I said, hypoxic brain injury. Hypoxia means lack of oxygen. So could be due to bleed in the brain, which is a part of kind of stroke. So all those things can lead to post accidents, post anything. So those things, when a patient does not wake up, we call it coma to make people understand. But coma does not mean that they will not ever wake up. No, that is not the truth.
ಇವತ್ತಿಗೆ ಪರ್ಸೆಂಟೇಜ್ ಎಷ್ಟು ಇಂಪ್ರೂವ್ ಆಗಿದೆ?
It depends again on your primary problem. It depends the baseline of your severity. So see, if they remain in coma for say 12 weeks, chances of coming back are very less. If they remain in coma for 2 weeks, 3 weeks, and then slowly started to improve, then probably their chances of recovery. And if they wake up after 5-7 days out of coma, slowly, gradually opening eyes and trying to understand. So it depends on how they are recovering every single day. So we can tell them more clearly based on their, so every day is a new day in the ICU. So we make plan for only 24 hours. We don't make plans for what we are going to do after 1 week, because we do not know what we are going to deal with in 24 hours or 48 hours, what complications might happen. So, and we should not give up too early too, because brain takes time to recover. Sometimes even can take 6 months to fully recover, 1 year to fully
ಅದರ ಕೇಸ್
recover.
ನೋಡಿದಿರಾ?
Yes,
12-13 ವಾರ ಆದ್ಮೇಲೂ ಕೋಮಾಲ್
yes,
ಇದ್ದವರು ವಾಪಸ್
yes,
ಬಂದಿರೋದು.
we have seen. I will not say all, but yes, occasionally we have seen.
Possibilities are
Yes,
there.
yes, but you should not, of course, you should know where to let go as well.
ಅಂದ್ರೆ ವೇರ್ that
So
is a very
that exactly. So those are the conversations which we have every day with our families, and where to give them hope and where to tell them, let's not make them suffer anymore.
a very thin line,
Very thin line,
important
yes.
line as well.
Yes, so it is a very, very hard conversation whenever, but our idea is not only for survival. There has to be some benefit in survival,
Meaning?
right? There should be meaningful recovery to some extent at least.
ರಿಕವರಿ ಆದ್ಮೇಲೂ ಅವರು ಸ್ವಲ್ಪ
They
ವೆಜಿಟೇಬಲ್
should
ತರ
not,
ಇದ್ರೆ
yes. So we should be very, very honest in those things. And
assessment.
if we don't know the answers, we should tell them that we do not know those answers. But if we have, based on medical evidence, based on medical judgment, if we can give them those numbers, that percentage, then we help them make some decisions.
Right.
So those are the
ಇಲ್ಲಿ
conversations.
ಒಂದು ನಾವು ಮೆಡಿಕಲ್ ಎಮರ್ಜೆನ್ಸೀಸ್ ಎಲ್ಲ ನೋಡಿದಾಗ ಪೇಷಂಟನ್ನು ಲೈಫಿಗೆ ತರೋದಕ್ಕೆ ದಸ್ ದ್ಯಾಟ್ ಡಿವೈಸ್ ಯು ಆಲ್ ಯೂಸ್ ಫಾರ್ ದ ಚೆಸ್ಟ್ ಅಲ್ಲ?
Yes.
What's it called?
Shock, defibrillator. Yes.
ರೈಟ್. ಸೊ ಆ
Yes.
ಥರ ಹಾರ್ಟನ್ನು ರಿವೈವ್ ಮಾಡೋಕ್ಕಿದೆ.
So there are very
ಬ್ರೈನಿಗೆ ಯಾವುದೂ ಇಲ್ವಾ?
no, unfortunately no. There is nothing like that for the brain. So brain neurons are not like see, when our skin peels off, it comes back. Neurons take the brain cells. They are not like our usual cells. They take a very long time to recover if they get damaged, if the damage is bad, and sometimes they may never recover back.
ಅಲ್ಲಿ ಎಷ್ಟೋ ಇದೆ ಒಳಗಡೆನೆ ಇರುತ್ತೆ, ಗೊತ್ತಾಗೋದು ಇಲ್ಲ
ಹೌದು.
ಯಾವ್ದು ವರ್ಕ್ ಆಗ್ತಾ ಇದೆ.
Yes.
Okay.
So I think we just need to, in terms of brain, we don't have any magic wand. We don't have any magic drug either. So all those are just things which we do. Main thing is, once the primary injury has happened, which could be anything, main idea is to prevent the secondary injuries. When I talk about secondary injuries, I'm talking about maintain their oxygen levels, maintain their blood pressure, maintain their carbon dioxide levels in whichever way, if they're not breathing well through ventilator. So all those things, maintain their sugars. So those are all secondary injuries you are preventing. Maintain temperature, prevent other infections, So that will automatically show up in the recovery of the brain.
ಅರ್ಥ ಆಯಿತು. ಸೊ ನಾವು ICU ಬಗ್ಗೆ.
Yes.
So ICU is not just always about machines, it's also medical judgment.
Yes. So it is definitely not about machines at all. Machines are just there to help us. Machines are just a tool to help us. For example, this mic. It is just a tool for you to reach out to your audience, so that it is giving clarity and
Right.
Same way, those machines are our tools, which we should use wisely, judiciously, and they help us manage those conditions. But they don't do everything. There is a brain behind those machines which should work properly and make decisions, because in critical care medicine, those decisions have to be very rapid, very
Oh.
quick, and the whole atmosphere is very stressful, right? So we have to stay calm in those situations. We have to stay calm, we have to take proper decisions, and we have to take care of the patient on one side, and we have to handhold the family on another side.
So true. I read
So-
one little story very related to this. You guys are literally the lighthouse. ಈ ಒಂದು ಸಮುದ್ರದಲ್ಲಿ ಒಂದು ಸ್ಟಾಮ್ ಅಲ್ಲಿ ಒಂದು ಬೋಟ್ ಒದಾಡ್ಕೊಂಡು ಬರ್ತಾ ಇದೆ ಅಂದ್ರೆ ಯು ಆರ್ ಜಸ್ಟ್ ಸ್ಟ್ಯಾಂಡಿಂಗ್ ದೇರ್ calmly and also guiding.
I just say that we are like those special armed forces, like special forces of the army, where we are only brought in when actually things are pretty bad, right? And nowadays, of course, we are picking up things very early. So whenever we have those meetings, I always tell that we should not have we should have very minimal code blues in the hospital.
What is a code blue?
Okay, so code blue is something which we announce when a patient is crashing in the ward.
ಸೊ ಅದು
like
ಫುಲ್
collapsing.
ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಕೋಡ್ ಬ್ಲೂ ಅಂತ ಬಂದ್ರೆ
So
immediate ಆಗಿ
yes, so
ಬರ್ತಾರೆ.
immediately there will be some 3 teams who will be going there, which will be critical care medicine, anesthesia team, and emergency team, and rapid response team.
ಅವ್ರು ಎಲ್ಲಿದ್ರು ಅಲ್ಲಿಂದ
Yes,
ಹಾಸ್ಪಿಟಲ್
so
ಇಂದ ಅಲ್ಲಿಗೆ
whichever, they will announce the room number, and so everyone goes there and tries to whatever manage and take care of the patient and bring them back.
ಯಾರ್ಯಾರು ಅನಸ್ಥೆಟಿಸ್ಟ್ಸ್?
Yes, critical care medicine and emergency medicine. So sometimes some hospitals have rapid response teams. So these are rapid response teams where these 3 departments will attend those calls, because these are the 3 departments which are always available in the hospital at any given time. So we don't leave the hospital, right? So so somebody or the other from the team will be there from these 3 departments, and so we are the super specialists. So post MD, we have been trained only for these critical care areas. So we are like, we have to go there, assess the situation, what is happening, and first of all take care of the airway. You control the, so when I was just telling you about, I'll come to all this later. So I was telling you that code blues should be reduced to minimum in a hospital. Why? Because we should be able to pick up sick patients early, where they should not reach the code blue level. Okay, if they are reaching the code blue level, it means
ಸ್ಲಿಪ್.
yeah, like we probably miss the early warning signs. I'm not saying you can have 0 code blues. That's not possible, because heart arrhythmias can happen at any point of time, like how standing on a bus stand and somebody collapses. Those things nobody can predict. But then there are certain symptoms and signs where patient shows before collapsing. So those are called early warning signs, right? So your breathing rate becomes more, your heart rate becomes more or less, blood pressure is gradually dropping, consciousness is not good. So all the signs when nurses go to the patient, so we tell them, if you feel they are not feeling okay, or if you feel that they are not looking good, you should just bring it to our notice. They may not be moved to ICU. No need to do that. You just inform us. We will come and see. If they need further care, we will just go through the history, or what is happening. Anything new has happened which has changed this scenario. So you must pick them early, so that we can prevent all the problems later on. So right now we are also becoming more preventive than reactive, as you say, than just react when the disaster happens. But what if we pick up certain things, like prevent certain things? Can't do everything, of course, but of course a lot of patients can be saved if picked up early.
ಎನಿ ಸೈನ್ಸ್ ದಟ್ ಈಗ ನೀವು ಹೇಳಿದ್ರೆ ನಾಳೆ ದಿನ ನಾವುಗಳು ಜನಸಾಮಾನ್ಯರು ಅದನ್ನು ರೀಡ್ ಮಾಡಿಕೊಂಡು Can they be more aware and conscious?
See, generally, it doesn't work that way, and we shouldn't be even worrying about these things on our daily life or every day. No,
Just do your basics
just
right
do
and
your
then move on.
basics right, and definitely whatever is written, everyone, whoever has come to this earth has to go one day. Only thing is we should live with dignity and die with dignity. So those are the things which we must
Never
always.
forget the
Yes.
two poles
Yes.
between which the
So
whole drama
in
is
between,
happening.
whatever best you can do, you should do. You should never feel, oh, I should have done that probably. That regret should not come. You should say that I did that. In spite of that, if it happened, it happened. What can we do? Right? We
Not in
can't
your
control
control.
everything. We think we can, but we can't. In fact, we can't control anything.
Coming from somebody who's seen life, loss, hope
Yes. Yes.
with such close
Yes.
proximity.
That is how all these things come in, because we ourselves, all of us, we feel that, oh, I shouldn't have, but who am I to say that? That control, that letting go is not easy, but at some point of time you have to let go of too much control,
How do
because
you doctors do it? Like you being one intensivist
intensivist.
yourself.
Yes. So don't let go of the patient, don't lose control over that, but certain times, in spite of doing everything, you end up losing some patients, right? So at that point of time, you have to find solace in something, that there is some higher power bigger than all of us, in spite of our best efforts. So that's where your destiny comes in, your what is written comes in. So in spite
Karma.
of your best medical efforts, you are not able to. So put your efforts, give your 100%, give realistic hope.
When
But
did you feel the presence of a higher power
always
very closely? Any case that you, without naming the patient, of course.
Okay, so we had this guy who was brought in from another hospital. He had this very bad pneumonia. Okay, he was on ventilator. He was on ECMO. ECMO is a very advanced life support where they bring out the blood and they give oxygen to the blood and put it inside, and. So he was on ECMO and his lungs damaged to an extent where he needed a lung transplant. Now what happens is, when you have so many pipes, tubes in the body, right? So infections are very, very common. So when he was brought in, all the cultures, everything was sent in, and it was already on day 15 or 17 on ECMO for him. And his blood started growing some kind of fungus.
You.
So you cannot keep those lines when there is something growing like that. Okay, because those are the source. So we, treated it, and so what we thought is probably change the lines. Now changing line is not simple, not easy.
Lines andre
Lines, the ECMO lines and everything, the cannula.
Pipe. Okay, got it.
Yeah, so because patient was transferred from another hospital as well. So we changed so when we were trying to change the ECMO lines, so we thought he may, he will definitely deteriorate immediately. But looking at his lung parameters, we thought he may sustain for probably half an hour, may give us half an hour and all that. So all that happened, and lines and everything we were about to change, and then once everything was removed, he had a cardiac arrest because of lack of oxygen. Carbon dioxide started building up a lot. So within, he didn't give us any time. So he had a cardiac arrest, but luckily we were able to change all the lines and revive him and put him back, and oxygen levels were achieved within some time. So we thought, we started telling the family that brain could have been damaged. We had informed them this may happen, but if we don't change this, he is 100% not going to make it, and chances of transplant and all those things with all these infections is not possible. So whatever we do, we have to do this first. So now his wife was a very, very nice lady, young chap, no kids, so very nice lady, so much of patience. Okay, and she said, no doctor, no problem, you continue whatever you can. We have patient started having some kind of fits, we call it myoclonic jerks, okay, which indicates that there is brain damage, hypoxic brain damage, one of the indicators. Now what happens, so we have not discontinued anything, we are continuing because family wanted us to see for next few days. So we can only we cannot do MRI brain with all those equipment to see the extent of damage. So we continued care, and it was another I think 1 week he started to open eyes. The myoclonic jerks kind of reduced, and he was on ECMO for next 2 months. He woke up, he started obeying. We mobilized him, moved him out of bed, did all that. His rehabilitation started and preparing for a transplant, right? So I think it took almost 2 months on ECMO, if I'm not, I don't remember very well. So, and then he got transplanted, and he is living a very good life today. So they message me, they on all the festivals, his wife, like so those are the things where you feel that okay, you can do something as doctors, you can do your work, but what is written here? And that is when you start feeling that how much can you predict, so that is why you should not take away hope too soon, but you should be transparent and honest.
And surrender.
Yes, continue doing your work, don't stop it, but tell the family what we are anticipating, because they understand. People have a lot of knowledge nowadays, and which is a good thing actually. Some doctors say we don't like Google and we don't like this, and I love Google. I tell them, you Google it.
Today's ChatGPT, AI. I mean,
you must. Why not? There is, when internet was not there, we were all like going to libraries, of course, searching each and everything. Today everything is on our fingertips. We can access it from anywhere.
Yep.
Yeah, knowledge is so free. So use it, but don't absorb everything. You discuss with us what you have understood out of it.
Don't
conclude with that. If Google has told you 5 million things, you can discuss with us. I will sit with you and I will make you understand. No problem with that.
Yep.
Yeah, but if you have doubts, read about it. In fact, most of the times they understand better when they come after reading, and the complications which Google tells, half the time we have not even, gone into that. So, which is a good thing sometimes.
Sure. ನೀವು ಆವಾಗಲೇ ಮಾತಾಡ್ತಾ ಯು ಸ್ಪೋಕ್ ಅಬೌಟ್ 2 ವರ್ಡ್ಸ್. ICUನಲ್ಲಿದ್ದಾಗ ಒಂದು ಎಕ್ವಿಪ್ಮೆಂಟ್ಸನ್ನು ವೈಸ್ಲಿ ಯೂಸ್ ಮಾಡಬೇಕು ಮತ್ತು ಜುಡಿಷಿಯಸ್ಲಿ ಅಂತ. ಇಲ್ಲಿ ನಿಮ್ಮ ಪ್ರಕಾರ ICUನಲ್ಲಿ ಅನ್ನೆಸೆಸರಿಯಾಗಿ ವಿಲನ್ ಆಗಿರೋಂಥ ಎಕ್ವಿಪ್ಮೆಂಟ್ಸ್ಗಳು ಯಾವುವು? ವಿ ಆಫನ್ ಹಿಯರ್ ಅಬೌಟ್ ವೆಂಟಿಲೇಟರ್ಸ್.
Oh my God. I think this world should thank ventilators for being there. If ventilators were not there is no critical care medicine without ventilators. You cannot save lives without ventilators. For example, when there is a bone fracture, say, do you not use crutches or wheelchair? Do you put pressure on that thing? You put a cast and you try to avoid, right? You try to avoid weight bearing or try to avoid certain things. When there is any illness, you try to avoid. So imagine your lung is struggling. Your oxygen levels, you and me, we are breathing 21% oxygen. That's the oxygen we need normally in the atmosphere.
Oh.
Now, patient is on so much of oxygen, saturating 70-80%. And if you say that ventilator is trying to kill you, no. Ventilator is trying. Saturation is like, for example, during COVID, people were talking about happy hypoxia. If you'd have heard about it, oxygen levels were 80 and they were happily walking, right? So
blood ಅಲ್ಲಿ oxygen
level ತುಂಬಾ ಕಮ್ಮಿ ಆಗ್ತದೆ. So ಆದ್ಮೇಲೆ oxygen probe, saturation probe ಅಲ್ಲಿ below 75 and all, I think sometimes it doesn't even pick up correctly. So 75-80 is the lowest, which you should believe. So imagine your oxygen levels are so low and you are still saying don't put on ventilator. So will you stop us in putting a cast or it is the same way. You are giving lungs to heal, giving time for them to heal.
But why do they fear ventilators? Andre infection agate antana pipe hogak hedrakotaara?
See, that's what, those are all misconceptions. Okay, so what happens, it's a very what do you say, magical thing actually. So what we do is we put a tube in the windpipe, and what you and me are breathing right now, right? So we try to give rest to those lungs, because when you're huffing and puffing, it can cause more damage to your lungs. You yourself can cause more damage. And in spite of that, you may not be able to get that much of oxygen, and ultimately all your organs fail.
Sorry.
Okay.
How though?
So what happens is we are taking over that function of your lungs. So what we are doing, we are telling you we are going to make you sleep for some time. You will wake up with a tube in your mouth. Don't worry about it. It is only to help you breathe. Once your breathing gets better, we are going to remove the tube. So that is how, if the patient is conscious enough to even understand, like in the sense, sometimes they're so breathless. Like, if you start telling them too many things, they get more worked
Anxious
up. Yeah.
ಆಗ್ಬಿಡು.
So we just tell them we are, going to make you sleep for some time. And when they wake up, we inform them. Like, that there is a tube inside your mouth and we are helping you breathe. Now that tube is connected to the unit, that ventilator unit. And that is helping the patient breathe and taking away their work of breathing. And once the infection or whatever may be the reason for ventilator, if it is primarily due to lungs or primarily due to brain, like patient is not conscious enough, as I told you, can't swallow, can't cough. So what do you do next? You have to put the tube and connect to ventilator. There the problem is not with the lungs. There the problem is with the consciousness. So ventilators are not only for lung issues. Ventilators are for various issues in the body. So you must understand why we are using it, and coming to the damage caused by those. So if you drive a car and if you don't drive it properly, it is going to cause accidents.
Right.
Same way, if you use any equipment for that matter, anything for that matter, it is going to cause problems. If you use those ventilators with proper settings, follow protocols, what have been taught to you, and, assess the lung conditions every day, and, see all the images, see everything, how the patient is breathing. And so that is what I said, everyday clinical decision making, every day, see if you can, when can you wean off the ventilator, when you can remove them from the ventilator, which should be assessed every single day during rounds, which we do in the morning.
So generally ventilators, the average usage time में रहता है?
It depends on the condition
Case to
again.
case.
Yeah, case to case. Generally, our normal, garden variety lung infections, hopefully, we expect that patients to come out within 1 week, 10 days. I'm just giving some random numbers. Don't take anything away from, anything like that. Oh, why my family is not getting better? No, it's not like that. So, but generally, commonly, if very simple lung infection and we are, seeing that improvement is happening very rapidly, 1 week, 10 days. But sometimes, as you would have seen in viral pneumonias, we have to put the patients prone. We have to, improve the oxygen levels. So those cases sometimes take 3 weeks, 4 weeks.
ಅಲ್ಲಿವರೆಗೂ ventilator ಅಲ್ಲಿ
Yes. And not like, I'm not even saying that rarely. This is the common ICU scenario. This is the kind of patients we treat every single day, and they get better and go home. And so many of them, they stay in touch with us.
So do not fear the ventilator. It
Do
is your
not,
life's
please.
support.
It's if one takeaway, message from this whole thing is, ventilators are not the villains. Please, if you do early, you may end up saving more lives.
Right. ಇನ್ನೊಂದು ಇಲ್ಲಿಂದ ಎಲ್ಲ ಕೆಲವು ಸತಿ ಕೊಡ್ತಾರಲ್ಲ ಅದೇನು ಡಾಕ್ಟರ್?
Tracheostomy. So what happens, you're putting this tube, as I said, right? So after a few days, say for example 2 weeks have passed, patient is not showing very good recovery, or consciousness has not come back, or patient has become too weak, because long stay in the ICU can cause real muscle weakness and difficult to wean from the ventilator. It can take time. The primary pathology has not improved significantly for us to completely remove the ventilator. So what we do is, we do it in the ICU itself in almost 90-95% cases. 5 to 10% cases we send to the theatre, where the necks are difficult, or airways are too difficult, or patients are too obese, or if we think that
ಮಾತ್ರ ಇಲ್ಲಿಂದ you open.
what small incision, we do it under proper guidance, ultrasound guidance, bronchoscopy guidance. So we see all the things, and then we do this small procedure. We make a small cut, put a guide wire, and then put the tube in. So it's a small procedure to help us wean off patients from ventilator, so that we can remove the machine. This can stay in.
Oh,
And once they're fully recovered, you can remove this tube and they'll be all right. You don't have to even do closure and all that.
Oh, okay.
Yes.
What does intubating a patient mean?
Same thing what I just
ಇವಾಗ ಮಾತಾಡಿದ ವೆಂಟಿಲೇಟರ್ support.
So this the tube. So what happens is there is no ventilator without intubation. So even during anesthesia, general anesthesia, they have to intubate the patient most of the times unless we are using some other device. So anyone who is going on a ventilator will have a small tube passed into the windpipe. So that procedure is called intubation. So we use a scope. It's called a laryngoscope. So what we do is we just put that scope blade inside. We see the vocal cords and we put the tube in. So and then connect it to the machine.
Some common doubts people have about critical care and ICU. ಇದಕ್ಕೆ ವಿಸಿಟಿಂಗ್ ಅವರ್ಸ್ ಅಂತ ಇರುತ್ತಲ್ಲ ಅದು ಯಾಕೆ?
This is a topic very close to my heart actually. So in our ICU, what we practice, and we have been doing it for very long time, we do not restrict too much family movement. We do not restrict. So what happens, 9 o'clock we start rounds, by 11 o'clock we finish handing over from night duty people, and then your visiting time starts, say 11 to 12. Now you are putting such a pressure on families that you have only this 1 hour to see your loved one who may be dying or may be recovering. We do not know, right? So we are just putting that pressure on them that okay, once this happens, I will not allow you to see the patient. That is where all that mistrust starts. Many families feel that it is too restrictive. So and there have been so many there has been evidence now where it has been shown that if you do not restrict so much the visiting timings by the families, the outcomes and the healing, everything may be better. Cognitive function, their recovery. So what we do is generally after we finish rounds and after we finish our important work in the morning, and unless something is really happening in the ICU which is extremely very busy and there are some 5 people crashing and we are tubing and intubating, generally that is not the case scenario. Most of the things get planned. So we allow families to visit more often after those rounds until probably 7 o'clock in the evening. So during night shift, we don't allow too frequent movements because patients have to sleep. Doctors have to do their work. Otherwise, what happens is most families after 24 hours of admission, they understand that we don't need to go too often. They are doing their job really well, and they see that how well we are taking care of the patient. So during that 24 hours, first 24 hours, all your new admissions, if you allow them little more time, they will understand what we are doing and they will understand the disease process as well. So what we do is we talk to them more often to tell them, to give them little bit more updates. See, of course, we can't keep giving updates because we have to work as well. But if you find some time, every 4 to 6 hours in the first 24 hours, that builds a lot of trust and communication becomes so much better. And they can see us doing a lot of things. How much everyone is taking care of. The nurse by the bedside, the respiratory therapist, the intensivists on, ground, how they are working round the clock.
Respiratory therapists, intensivists.
Yes. So we have 3 doctors on the floor at any given time. And 2 senior doctors, 1 junior doctor. Then we have nurse 1:1 ratio for ventilator patients. So we should not restrict. I don't know, people may not like it, but I feel that we should give families some more time in the ICU to visit their loved ones, because that fear has to the kind of fear which they feel when they're sitting outside in that waiting area, and how they must be feeling that their loved one is there and we are not even we can't be even close to them. And in fact, if someone is not really doing well, we know that they are not going to come out of this illness, what we do is we give them chairs, we make them sit with the patient, we draw curtains and we make them comfortable, and so that at least last moments they should not feel that we were not even with the patient. So those are all humane things which we must do. And I always tell all my nurses and all my colleagues, doctors, when we talk about it, that see, they have given their family member to you in your hands, trusting you completely. Now it is up to you how you manage. So to keep that trust, we have to give our best, and we have to treat them how we will treat our own family member. Don't do anything which you will not do to your family. Whenever you are doing anything in medicine, think, will I do this to myself or to my loved one? If the answer is no, probably you should discuss. But of course, there are things our thoughts and perceptions may be different from certain families. There, I think we should discuss with the families, like what are their wishes, how the patient wished, what he would have wanted. For example, if a 90-year-old comes to you who hasn't been very active in the last few months or few years, bedridden, not very good quality of life, but kids are not even staying because they may not be around, they may be abroad, right? So sometimes it comes from that thing of, I have not spent enough time with my parents and now they're going. Probably if I can save them. It comes from that, that feeling, that emotion, that, if we can. But if they had lived with them, that 90-year-old person, and lived with them over last 1 year or 2 years and seen them suffer, probably they may not want to put them on ventilator or dialysis when the organs are failing, or if they are not doing very well. So those are the things which you should speak to them, and of course ultimately whatever family wishes will be done. And then we ask them how the patient would have wanted, what the patient would have wanted. Patient's wishes are very, very important. If the family says no, they did not wish to suffer or prolong unnecessarily if the outcome is going to be poor, right? So no meaningful recovery. So maybe they had a good life. So let us not do unnecessary things. Medically, yes, probably treat everything whatever possible, but probably not do too many invasive lines and pipes and tubes. Everyone should not die with all pipes and tubes in the body. That's not how all human lives should end. Just because we have it doesn't mean we should do it.
True that. So ishtala nodidirala, in your opinion, what ICU complications can be prevented as on 2026?
I think we can do better with probably some infections. We can do better. Hand hygiene.
Pipe.
See, any plastic in the body can cause infections. We are full of bacteria. We are full of our own microorganisms are enough to give us all kinds of illness. When the time comes, when the immunity is down, they can invade us, right? Because we don't know what we are harboring. We might be harboring all multi-drug resistant bugs. We might be traveling somewhere. We might be getting something. It may be there in the body. So when the immunity goes down, that may be, attacking us. We do not know that it has always come from where, right? So probably in terms of infection, stricter hand hygiene. Like, anyone who enters the ICU, we tell them each bed has a hand rub. All doctors, our nurses offer hand rub. Even if someone forgets, we tell them, please use hand rub before touching the patient, after touching the patient. Use gloves whenever possible, those simple gloves by the bedside. So those are infections. I think we can do a bit better with that part. And most of the other things, I think we are doing fairly okay.
I have one rapid fire round.
All right.
Around one ICU machine people misunderstand the most.
Ventilators, for
Apart
sure.
from that, anything else?
Dialysis, sometimes, when we talk about dialysis as well, if it is all acute problem, most of the people will return their kidney functions back if managed properly, and if we give them time, if their kidneys were normal at the baseline. So don't fear that if somebody is going on dialysis, it is not, of course, 15-20% you cannot say. They may go on permanent dialysis, but generally when it is all happening due to acute infections, it is life-saving again.
Got it.
Then I think these are the main two things which people ask us questions most of the times.
Most overrated ICU intervention?
I think sometimes we jump on to do some procedures than taking care of the whole scenario, whole patient. Like BP is low before starting, before giving too much of good fluid and doing things. We sometimes go and start inserting art lines and finding art lines like an arterial line, which is an invasive line, where we check beat to beat blood pressure. So that is important, of course, when your medicines are at a very high dose. We need those lines and tubes and pipes, but it is not like you leave everything and only focus on that. You first resuscitate and do all that, and then once you have reached certain stability, then start trying and wasting time. If you have ample manpower, like one person can do this, one person can do this, you can delegate the work, then fair enough, you can go ahead and do all that. So I think those things, and otherwise overrated, I wouldn't say anything is any overrated or
So
Yeah.
what's the most life-saving ICU intervention apart from ventilator?
Apart from ventilator, I think defibrillation when the arrhythmias happen. If patient is in shock and patient is going in for, as you would have seen at the airports also, right? Those shock you were asking me, right?
The
That
T-
yeah, at the right time, if given a defibrillator at the right time, you can save a life, right? So then, of course, as I said, dialysis machines, like really life saving when the time comes.
One question families must ask an ICU doctor.
What is the plan? What is the plan for today? What is the plan for today? Please talk to us. And I always tell them, you talk to me, I will sit with you, I will make you understand. We keep on asking them, do you have any more questions? Do you want to ask us anything else? Because sometimes there is so much of hesitation, like whether we should even ask this, whether we will sound silly asking this.
Right.
Nah, there's nothing. No, nothing is
Ask.
silly. Just ask, just communicate, get your understanding better so that we can communicate better. Because sometimes unknowingly we start using medical terms in that routine thing. We don't even sometimes understand that family may not have understood the whole idea, and then they must do that. And I think, communicate as much as possible. Ask us the plan of every day. Don't ask us what will happen in 2 weeks. We don't know the answers, but ask us what you are going to do today. What is the plan? Are we waiting? Are we just monitoring? Are we doing any procedures? Are we planning any diagnostics? Or we are just giving time to heal?
As we speak, I know it's a very personal question. How many people are there in your ICU?
So we are a 45 bedded unit, out of which we have 20 beds for the multidisciplinary ICU, where we keep all, as we were discussing, all kinds of infections, sepsis, pneumonias, any tropical infections, strokes, sometimes even complicated myocardial infarctions, those post-heart attacks, stenting. So long-term ICU care due to various reasons, malignancies, immunity, low immunity, and onco patients. So this is multidisciplinary ICU, trauma, stroke. So
What's
we
the
are
other one?
always full.
Oh.
Generally, we don't have beds. Like almost, you can say, almost every day, we are just full. It's but see, you must understand, it's only 45 beds out of 200 beds. So, but yeah, which is a good number. Yeah. So other ICU is surgical ICU, where we receive our post-surgical patients, and post-transplant patients. There is a transplant ICU. So we keep our CABGs, like those bypass grafts, then valves, and any complicated abdominal surgeries
So all the post-surgery care
is in the
needs
yes.
ICU because of
Not all,
infection.
not all. Only
Okay.
if it's a very complicated surgery, and we are expecting some hemodynamic problems, like ups and downs in the blood pressure, and patient needs so many monitoring things, so which cannot be done normally in the ward. So they stay for a couple of days, and generally they go to the room without major issues, and we can pick them up early if there are any issues. If, for example, if bleeding is happening, you can pick it up like, okay, drain is coming more, you inform the surgeon, and you just do the needful.
Got it. Now this or that, ventilator or oxygen helmet?
Both have their own roles, so one cannot replace the other, so we have to decide where to use what.
But generally, is there a pick, like, which is probably the go-to?
So, go-to is always oxygen, simple oxygen mask, okay, or nasal prongs first, but it can progress to ventilator within 12 hours, right? So you start with 4 liters, 2 liters in next 3 hours. That's why I said we communicate with families so often, because after 6 hours I may be telling them, now patient is needing NIV. NIV is non-invasive ventilator. We put a BiPAP mask, and we push air from outside. You would have seen during COVID those videos. And then high flow nasal cannula, we are using quite a bit of that. So those are all devices, various devices like helmet, HFNO, NIV, before going on to ventilator. But all patients are not candidates for all these devices. Sometimes when they come in too sick, we may have to directly put them on ventilator. But sometimes we wait. So as I said, every second monitoring, and we anticipate, okay, this patient is going to deteriorate. Now the question is, when do we do the needful? So those are the things. That is why you need on the ground intensivists, hands on all the time in the ICU. You cannot say, I saw the patient at morning 8 o'clock, I think should be okay, we'll come back at evening 8. No, that's not intensive care. You can't.
So what's the difference between a specialist doctor and an intensivist?
Oh, good you asked that. I would really like to tell you that. So, nowadays we are lucky that, especially in Bangalore, critical care is really good. Like most good ICUs are doing wonderful job. They are like really doing a good job. So, an intensivist is a very highly trained, specially trained doctor post graduation, who has been trained only in critical care. Like they have been trained only to take care of patients, those who need those rapid decisions, working in that whole thing, making quick decisions, doing all the procedures. So basically, you should have the clinical judgment, you should have the skill, you should have the wisdom to use all those things, and your hands should be steady at that time.
Oh.
Yeah, because you're doing so many things, and you should have empathy. If you don't have empathy, you can't practice critical care.
Right.
It is very simple. See, in OPD, you see cough, cold, fever. It's okay, even if you don't explain too much physiology, pathophysiology of everything, it's okay. But when someone's loved one is dying, you are holding hands and you're explaining it to them that, okay, this is what all is wrong. Imagine to a lay person, to a common person, right? You are telling kidneys have failed, liver have failed, lungs have failed, putting on ventilator, dialysis, come tomorrow. It cannot work like that, right? You have to explain everything, why it has happened. What started it. Right? What is the disease process you're dealing with? So there is an infection in the lungs. Your lungs are filled with a lot of fluid. He's unable to breathe right now. There is no oxygen reaching his body, or there is an infection in the body. We need to remove it immediately. There is a pus. There is abscess. If we don't remove it, he will go into shock, or he is already in shock. We need to remove that. We may have to amputate. I've had a patient who, don't want to say this, but yeah, those fish, they eat this thing, right? He had an infection of the leg, and he went to this naturopathy thing.
Oh.
Okay, so that he can heal the cellulitis, and they were doing this fish therapy, as they call
Leave
it.
the dead skin or something.
Yeah.
The infection. I don't know.
Yeah. So he came back with such severe necrotizing fasciitis. It's a very bad infection of the whole, skin, muscle, soft tissue, everything, like flesh-eating bacteria.
Oh, damn.
Yes.
It had gotten into the body?
Yes, everywhere. And then from there, all the toxins spread into the body. And we lost him in spite of doing everything. We had to amputate, we had to do all that. But the blood pressure was not picking up in spite of anything.
Flesh-eating bacteria?
Yes, because they just start eating. You can't do anything basically. So
So
these are the
please,
things.
I mean, it's so scary that
It is
we
scary.
give our
So
own body
yes,
so lightly to random
yes, so
experiments.
you have, don't do it. Like, even if you don't like this medicine, allopathic medicine, uh, even if you don't like, do it for yourself. Like, even if you don't like, that's okay. Don't do too many things, but at least take a second opinion before you are going for these kind of things. Very important. So as we were coming to critical care, sorry, I'm just straying. Intensivist. So we are like captains of a very distressed ship, right? So we are, so a person may have, as I said, all these organ damages, and then you have to communicate with all the important either the primary team who was looking after in the ward, and now we have taken over and we are taking care of the patient. So we have to inform them, we have to inform the family. If there is new ECG changes, you have to involve the cardiologist, whether we need to send to cath lab to do any angiogram, or if there is anything not conscious enough, whether to do an MRI. So basically you are seeing the person as a whole in critical care. The intensivist sees, we will never see as an organ wise. Okay, we will see it as a full body. Like, if I'm not only looking at the heart, I'm
Right.
not looking
A
only,
holistic-
yes, the holistic thing. How is the patient looking today? If I feel everything is good on numbers, but everything is looking good on the chart, but if the patient is not looking good, so those are the things which we pick up. And a lot of our colleagues, they call us in the wards to just see those patients. Can you have a look? We too feel that patient is not doing well. So we are like the last call for everyone. Like, when everyone is okay, let us take a second opinion, or let us probably ask them if we need to do something differently, or do we really need to probably escalate the care. So that is what intensivists do. And we are not, our work is never rounds bound. Like, our work is every minute. We cannot leave the ICU unattended at any point of time. So if anyone is leaving for lunch or anyone is leaving for a break, there will always still be one doctor on the floor, so that to handle if anything happens. So those are the things which intensivist led ICUs do. So, but in earlier days, what would used to happen, there weren't any trained people who would sit in the ICU. There will be some MBBS doctors, post MBBS residents, right? So they will be just taking orders from the physician who is sitting in the OPD and giving orders, like, have seen the patient in the morning and then in the evening. So that is not intensive care.
Right.
So
much
but now people have understood this. So when they come inside the ICU, they ask for the ICU doctor. Right? They ask for who is looking after the ICU. So I think those things have changed with time.
Aggressive treatment or conservative care? What would you pick?
Sometimes doing less is more, but sometimes you have to be really aggressive. Depends on what condition you're dealing with.
Right.
Case to case.
Early ICU admission or late rescue?
Always early ICU. Always. Sometimes you may even prevent ICU admission if you involve the ICU team.
Now it's about procedures that usually scare the families. Why so many tubes, lines and monitor? How to answer that in a sentence?
So because each device has its own role, and it gives us a lot of answers about each organ and helps us manage each organ.
So don't worry. Look
don't
at it
worry.
objectively.
Just don't look at those pipes, tubes and lines. Even though we explain everything, see, if you have a food pipe, it's to give them food because they're unable to eat, right? If there is a catheter because not conscious, for urine output monitoring, if your kidneys are not having good blood flow and your creatinine is rising, we need to monitor the urine output.
Right.
Otherwise, how will we know how much urine is he passing every hour? So we always laugh when patients' urine output drops. We also forget how much, how many times we have gone to the washroom because it is so stressful. Like, if patient is not passing urine, we are kind of bad.
This is for people who question about patients turned face down. You spoke about prone ventilation.
This has been going on for many years actually, but people got to know about it only recently during COVID. But we have been doing it in the ICUs from very, very long time, and it has been shown to improve outcomes. So what we generally do is, if somebody's oxygen levels are not improving, in spite of being on ventilator, being on very high oxygen, because through the ventilator we can give up to 100% oxygen, right? So, but sometimes what happens in certain areas of the lungs, the blood flow is not good, and in certain areas the air which is reaching or the oxygen reaching, that is not good. So basically there is a mismatch. Sometimes where there is more blood flow, the oxygen is not reaching. So your lungs are like sponge and it's filled with the liquid. Okay. So what will happen when you're having liquid? It will become heavy at the base, right? Now you flip it, right? So you flip it and you see that you're more the other side is opening up again, right? So you are making use of that, so which has not been used before, right? So you are improving. So this position has many advantages. Okay, so it will help you improve the basically ultimately oxygen levels in the body. So if you are on 100% oxygen, instead of going on ECMO as a next resort, you would always want to try this position before subjecting somebody to ECMO. If of course if there is no imminent organ failure, and if you feel that they will sustain this, of course if their blood pressure is crashing and you need to do ECMO, you need to do ECMO. But this is a position which you must try wherever you can, and we have seen amazing results with it.
Percentage being?
First is being from 100% your oxygen levels drop down to 40%. Like on ventilator, if you were giving 100%, you are now giving 40%. Patient is on prone, but you have to be very careful that all the pressure areas are properly taken care, should not develop pressure sores. But in spite of all our efforts, sometimes they can have skin peels, and if patients are very heavy, they can have those little bit of redness and probably sometimes skin peel. Those things can happen. We tell the families before doing it, but all those things are cosmetic. This is life-saving. So you turn them, you wait for 18 hours, right? 16 to 18 hours. Your oxygen levels, you will get to know within 6 to 8 hours if your patient is improving or not.
They turned down for 16 to 18 hours continuously.
Yes. And then you turn them supine at the end of 18 hours once you feel that okay. But you have to turn them at least once a day. So when you turn them, you give them position change again. Now if again your oxygen levels are dropping, that means they need another cycle of proning. So that is how you do this, repeatedly, and until gradually when the disease process starts settling, all the lungs are getting better. It's like a thick fluid filled in the lungs, like pus kind of thing, the inflammatory fluid, which is causing all this due to infection or pneumonia or whatever, like we call it, right? So gradually, once the disease process starts settling, automatically the patient starts improving even in supine, like the normal position. So we don't have to put them again. So this is what we do very, very commonly in our practice, especially when the oxygen requirements are very high. But good thing is now families are aware of it. So,
So about ECMO, is it a miracle machine or a misunderstood last resort?
It can be both, I feel. It is sometimes can cause miracles where it is used. Okay, for example, if someone has taken a very heavy dose of some drugs or poisoning where blood pressure is crashing. So it is basically to support your heart and your lung based on which kind of ECMO you're using.
That's right. That's a device which supports both at
Both,
once.
yeah. So which way you're using it, whether you're just supporting the heart, you're supporting the lungs, you're supporting both. So, and the condition for which you're using, whether you're using it only for lungs, pneumonia, whether you're using it for heart failure, whether you're using it for some poisonings, whether you're using it for, various indications where
How
we
does
use
the
it.
machine look?
It's not a very big machine. It's a very compact machine which has an oxygenator and, like maybe not even this much space it would fill, and then there are a lot of pipes and tubes and lines which have to be taken care than the machine itself.
So every time the pipes change, of course.
No, we hardly change those unless we really need to, because that cannot be put back again and back and forth. It's not like that. So those cannulae, they remain. Only sometimes if there are any blockages, we change those filters, those oxygenators, all those things we change. So, but generally, if there is no infection, we do not change the lines so frequently. So it can be a miracle machine, but should be used only when we feel that definitely it is going to help the patient. Yeah. So as I said, like, we have saved so many patients with it. And, even during COVID, even after, otherwise post-COVID, even before COVID, in fact. So those H1N1s, influenzas, even in those patients, not only COVID. So, so it can be both. But if not used properly, or, if you don't know how to handle it, and if you don't have the manpower or the skill to do it, probably ask for help. Like, there are a lot of people who are doing this in Bangalore. So ask for help, and there will be people to help you.
Now some myths for you to bust in one line.
Yes.
Does being put on a ventilator mean a patient will never recover?
Absolutely no.
Are ICU infections unavoidable no matter how careful a hospital is?
Yes.
Is ECMO only for patients who are about to die?
No.
Does dialysis in the ICU mean lifelong kidney failure?
No. This I tell multiple times, no.
ICU outcomes mostly are luck rather than medical judgment, are they?
I would say both. If your luck is good, all the things will go well. The medical judgment will go well. The treatment will go well. That is where for example, you have put in so much hard work, right? You have come up to this stage in life. Would you put it to just luck?
Definitely
No,
not.
right?
I've
But
done
luck was there. That's why you did all this.
Oh,
Right?
perspective.
Yes. So,
It is a silent.
it drives you. Your destiny
partner.
drives you towards that.
Oh, wow. I think that's the question we would find an answer till the end, I guess.
Yeah.
Is the will or is it the destiny?
I think it's both. But if it's in the destiny, you will have the will.
Now that is where.
So,
who drives the will?
Who
Is it
drives
me
the will?
Or is it some
That you will have to put an
supreme?
effort. We can't say that it's written in my destiny, because nobody knows destiny. So that's why that will come from inside when it is in your destiny. But of course, you can't just sit idle and think that, everything will. No. You have to work towards it.
More technology in ICU always equals to better survival? Is it so?
No, it's always the
Judgment.
personnel, yes, who are driving that technology. It is an assistant. It is, helpful to us, but it is really, really wonderful, but no.
Is it true that younger patients who come to critical care have better chances of recovery?
So definitely in certain cases they have, in certain cases, I will not always say yes, but in certain cases, like for example, if a 40-year-old falls sick and an 80-year-old falls sick, the machine is 40 years older, right? So the resilience, the recovery is bound to happen much more, and the ability to fight back is much more in younger people. But if at the baseline the younger person is much worse than a 70-year-old man, then of course. But I think yes, like how kids are so resilient.
Right. I think this is a common doubt everybody would have. Brain death, is that the same as coma?
No, it is one part of it, that patient is unconscious, but there are other parts of it which means that this coma does not have breathing. Okay, this coma is without the breathing. Your patient cannot survive without those ventilator machines, pipes, tubes, or whatever, or those drugs cannot survive without that life support
Right.
machine.
That is coma.
But if it is just pure coma and not brain death, the patient's breathing will be their own. They will have breaths. Okay, their brainstem reflexes. For example, what we are talking, your consciousness, right? Then when you shine torch in the eyes, you see that your pupils dilate and constrict, right? Those reflexes. When you move head towards one side or to the other side, automatically your eyeballs move, right? Right? So those things are all gone if you don't have brainstem reflexes. But in coma, those may not be absent. Those may not be absent. In some brain issues, those things also may be absent. So we have to come through the history. Then there has to be certain evidence of a neurological event which can tell us that yes, this patient can go towards brain death and not just coma. And then you have tests for those. And these are all the tests we do. We check all these brainstem reflexes. And then most importantly, there is no breathing. The moment you take off the ventilator, they will die in no time. So that is the most important difference. There is no breathing happening on their own. You cannot put a breath back inside. So brain death is legally death in our country. It's a legal death.
Oh.
Yeah, it was.
There's never a person who's come back from that.
No. So if someone is declared brain dead, it means they're legally dead. It has been like that since 1994.
Legally, matlab?
Legally means you don't have to have cardiorespiratory death. Like your heart and, your heart can still be beating, your body may be warm. It is not cardiac death or cardiorespiratory death, right? But person is brain dead, but all other organs are functioning well with the support. Of course, if you remove all the life support, they will die ultimately. But government recognizes it. The law recognizes it. You can declare somebody brain dead and remove everything.
That is what is called legal death.
Yes. So it is not like only we talk about, no. And this is a prerequisite for organ donation. Deceased organ donation means brain dead organ donors. So only after you declare somebody brain dead, after that you can only talk about organ donation.
You have donned many hats, and of course one of it is you are part of a community which takes care of organ donation and all of it.
Yes, a member of Jiva Sarthikate Brain Death Advisory Committee. Yeah, so we are trying to create a lot of awareness amongst people, right? Because there are so many myths and so much of fear.
What's the biggest you're fighting even today, like about organ donation, the myth, taboo?
Actually, it is more about the diagnosis. I'll tell you why. Because people would have heard about brain death. Like most people know about brain death, and when they don't see their loved one moving from last few days, couple of days or one day, they feel that, is he even alive? Or is he ever going to come back? They themselves ask, right? Now, that taboo comes from the time when that question is asked. You are asking somebody to donate something at a time when that is the worst time in that family's life. So that is why this has to be extremely sensitive.
Right.
It should never be asked in the same breath. You should never ask, he's brain dead, will you donate? Or no, you should not. You should give them time. First of all, you have to make them understand what exactly is brain death.
Right.
You have to bring them by the bedside. You have to show them all these reflexes. You have to show them that he or she is not breathing. And you have to do those tests, apnea test as we call it. That is a confirmatory test. So you remove the ventilator, you give oxygen, you wait for carbon dioxide to build up. And then when that carbon dioxide builds up to a certain level, we call it apnea positive, which indicates the patient is brain dead. So that is the time of death. And those tests are done 6 hours apart. And then 4 doctors sign that document. So the taboo is, I think, how we present it and how much awareness does the community have. Right. So we are trying to, do programs where we talk about, it should be a dinner table conversation. It should not be hush hush and organ donation. No, why? All over the world, people are doing it. Like, you are converting a loss into life. what are we going to do if that death has happened now, tragedy has happened,
Right.
right now, we are just going to cremate or bury, right? What, it was just a meaningless death. Young people, most of them are young, because most are traumas, or young strokes, or generally the victims, right?
True.
The road traffic accident victims, if we are talking about that context. So at least it is giving some meaning to their death. Otherwise, why someone at that young age should die? So you have to make the families understand that that loss is converting into a life and multiple lives. One
Right.
organ donor can save up to 8 lives and can change up to 75 lives
Oh, wow.
with tissue donation, with
Lot of other
lot
things.
of other things. So
75 lives and 8
yes, 50 to 75 lives and eight other
organ.
people. So imagine somebody's loved one is going for, say, dialysis every alternate day. They are getting poked with all those needles, and imagine a call comes that you are getting an organ today, probably you're getting a kidney today, right? You know how their lives change. And there also, some of them are very young people, those who are undergoing
Right.
dialysis. Imagine your whole life changes after that. You are no longer going to hospital every alternate day. And why? Because one family made that decision, and that person is like a god to that.
Even
See,
in loss, they
one,
gave something.
they gave something.
They
So
gave life.
they gave life, so it is a bridge. It is a bridge between that loss and life. So
It was a very tough call for me as well when I lost my mom overnight
yes
through a cardiac arrest. I was in shock. I could see her gone right in front of me. Still, I took the decision of donating her eyes.
that's
And I was hell
amazing.
bent, like I wanted to see that being taken away. But my Jiju, who's an eye specialist, he said, now this is a line you're crossing. Go
Yeah, you
out.
should. Yes.
But,
Yeah,
pain
that's
can redirect.
yes, really, like somebody
can
blind
read,
who could not see will be seeing through your mother's eyes. So those are the life changing things we are talking about when we are talking about organ donation. So people should ask more questions, and in fact nowadays the awareness is better, and people themselves, if we talk about brain death, and then we keep quiet after that, we give them time to process it, because it is
Right.
a shock. You give them time to understand what has happened, and then sometimes they ask us, is there a possibility to donate?
True that, true
What
that.
do you feel we should be doing? Then you give them all the options they have, and you are actually, like, that one god gives us life, that life has been given to all of us. Now this is the second life which their loved one is giving to, so they are like, actually like god to that family,
True
to the
that.
another family. So I think all of us, as I said, have to die one day. And when the death becomes so meaningless, when they haven't even seen life properly, and they are dying at such young age, and in fact donation can be at any age, there is no age limit to that.
So, how to donate?
You can be an organ donor. So in fact our government is really really pro awareness, pro organ donation, and our Jiva Sarthikate, our Soto Karnataka, they're doing a wonderful job. And anytime we call them, they are there. Our health minister, he is really really helping to create more and more programs and awareness.
So, you
And
go to any hospital, you can donate.
it's not like that, no. So there are non this thing organ transplant retrieval centers, where you can request the government body that we would wish to donate, how should we proceed, or you can even tell the treating doctor that we wish to donate, how shall we proceed.
So, how do
So
I sign up for organ donation?
You can go to Jiva Sarthikate website, and there is a scanner, and it's very
Simple.
very simple. So many people have done it, pledging during our organ donation, World Organ Donation Day. So I think we should talk about it with more openness. And, many states are giving state honor to the donors. In fact, Orissa is paying, giving financial help to the donor families, almost 5 lakhs. So, other states are helping in funerals. so many other things we are also doing that.
To help
So
them.
to help them, and this is
keep their
the see, when they're
consciousness.
donating, what we have to do is we can't do anything else. We can't offer them anything, right? But what we can do is take care of them during that difficult time. Give them a room, a private place to mourn or to grieve. Provide them with simple food, like they may not be even able to eat during that time.
Right.
Send your grief counselors to them to talk to them, give some psychological support, and arrange for the funeral, the transport with the ambulance, or so those are the minimum things which you can do for those donor
I'm sure.
families. Yes.
Thanks, doctor. I think you've thrown so much light about how to live and how to live after you're gone.
Yes.
I mean,
Yes.
lovely talking to you.
Lovely talking to
Yeah.
you too, Rashmi.
Until next time.
Until next time.
I'm
yes.
sure you will continue to stay curious with your purpose in life and the profession that
Yes.
you've chosen.
Yes. Thank you.
How did you like your first podcast?
Yes, first podcast. Wonderful. Really, really good. I mean, I'm really impressed the way you conduct the whole thing, and how you make the other person talk and make comfortable and bring out all the good content, I would say. Like because it's not easy to have a conversation when you're meeting for the first time, and such deep topics, and it means you yourself are really well read and you have done so much of research on those things, which is excellent. So
Thank you, ma'am. Student for life. Of
Yes.
course, just curious.
just curious.
Uh,
Stay curious. Yeah.
Thank you.
Yes.
Lastly, would you like to nominate 3 guests? Yarana now just curious karkond barbeku who can add more light to this world through their expertise and knowledge.
Oh, that's wonderful. Okay. So I think you can call our liver surgeon, Dr. Sonal Asthana.
Mhm.
He is doing a very good job. Then you can call our CEO, Dr. Prashant. You should call him. I think, you must probably, talk to him and how to handle all the stressful situations in the hospital and management of hospital, and how all these branches of Aster they are managing, and, how corporate world is in the
How
hospital
corporates
industry.
Yep.
Yeah.
Right, right.
So many myths and so many things about corporates, right? Those bills and those things about, so you can
Sure.
talk to him, and probably who else, all are good, like maybe my mentor, he's also a critical care physician, Dr. Jose Chaco. So he works at Narayana.
Mhm.
So probably you can invite him. Wonderful gentleman. And what I am today is, of course, in critical care is all because of him. And how much he has taught me critical care and about life and all those very, very emotional things in critical care, and how you do all the important things. So I think, probably you should know that.
Lovely.
Lovely talking to you.
Thank you. And it's a tradition that we give a book to all the guests.
Oh, wonderful.
Yeah. This is a book, 8 Stages of Spiritual Awakening.
Wow. Okay.
Yeah.
I love reading books, and but this is really good.
This is about yogi, jnani, jignasu,
Nice.
mumukshu, Satchidananda Atman, Jivan Mukta, Sthita Prajna, and Buddha. So all of these
Okay.
phases of spiritual awakening, I'm sure
Just
this
curious.
can give you some perspective
Yes,
while
definitely.
you see life and loss so closely.
Definitely.
So yes, dear Gagan, to stay curious, sky is the limit, and your name reminds you of the possibilities of that every day. Love and light.
Thank you so much, Rashmi.
There you go, ma'am.
Thank you. Please call me Gagan. Yes.
And of course, we have a treat box.
Okay, lovely.
This is
Coffee
only
with Karan, huh?
this is a
Not a good
box from Polar Bear. Only when you think you need to have like a cheat day kind of a thing.
Oh,
So
I have lot of
Sunday,
cheat
Sunday love for
Yes.
you from Polar Bear.
Yes.
The ice cream Sunday zone. So I guess Ivathu, we have spoken so much about life without meeting the other end, that is loss. So stay conscious. ಮತ್ತೆ ಇವತ್ತು ಕೊಟ್ಟಿರೋ ಎಲ್ಲ ವಿಚಾರಗಳ ಬಗ್ಗೆ ಕೂತ್ಕೊಳ್ಳಿ, ಮತ್ತೆ ಮೆಲುಕು ಹಾಕಿ, ಆ್ಯಂಡ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ಲಿ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಿ. ಡೂ ಲೆಟ್ ಅಸ್ ನೋ ಇನ್ ದ ಕಾಮೆಂಟ್ ಸೆಕ್ಷನ್ ನಿಮ್ಮ ಫೇವ್ರೆಟ್ ಪಾರ್ಟ್ ಯಾವುದಿತ್ತು ನಮ್ಮ ಕಾನ್ವರ್ಸೇಷನ್ ಅದರದ್ದು. ವಾಟ್ ವರ್ ಯುವರ್ aha moments, what were your moments which were like a slap on your face? All of it, I'm sure you will stay honest to those reflections and do something with it. Until next time, ಲೈಫಲ್ಲಿ ಏನೇ ಕಳ್ಕೊಂಡ್ರು ಕುತೂಹಲನ ಕಳ್ಕೊಬೇಡಿ. ಆ್ಯಂಡ್ ಲೈಕ್ ಐ ಆಲ್ವೇಸ್ ಬಿಲೀವ್ ಇನ್ ಸ್ಪೆಂಡ್ ಟೈಮ್ ಎಫೆಕ್ಟಿವ್ಲಿ. ಒಂದು 10 ನಿಮಿಷನ ನೀವು ಎಲ್ಲರೂ ಕೊಟ್ಟಿದ್ರೆ ಇಟ್ ಬೆಟರ್ ಆ್ಯಡ್ ಸಮ್ ವ್ಯಾಲ್ಯೂ ಟು ಯುವರ್ ಲೈಫ್. ಸೊ ಯೂಸ್ ಸೋಷಿಯಲ್ ಮೀಡಿಯಾ ವೆಲ್. ಆ್ಯಂಡ್ ನಾನು ಕೂಡ ನಿಮಗೆ ಸಿಕ್ಕಿರೋದು ಸೋಷಿಯಲ್ ಮೀಡಿಯಾ ಮೂಲಕನೇ. ಸ್ಟೇ ಅವೇ ಫ್ರಮ್ ಡೂಮ್ ಸ್ಕ್ರೋಲಿಂಗ್ ಆ್ಯಂಡ್ ಲೆಟ್ ಇಟ್ ಬಿ ಅ ಕಾನ್ಷಿಯಸ್ ಸ್ಕ್ರೋಲಿಂಗ್ ಎಕ್ಸಸೈಸ್. ಆ್ಯಂಡ್ ಮತ್ತೆ ನೆಕ್ಸ್ಟ್ ರೀಲಲ್ಲೆಲ್ಲರೂ ಸಿಕ್ಕಿರ್ತೀನಿ ಅಥವಾ ನೆಕ್ಸ್ಟ್ ಫುಲ್ ಯೂಟ್ಯೂಬ್ ವೀಡಿಯೋನಲ್ಲಿ ಸಿಗ್ತೀನಿ. Take care, and now Nima Rapid Rashmi signing out of another beautiful episode with one and only Gagan. True to her name, the topics that we have explored, sky is literally the limit. Extra time sikto, we've tried to do our best. Take care, and thank you, Gagan.
Thank you so much. Rashmi.
Wish you more love and light, and hope always.
Thank you so much. Wish you the same.
Thank you.
Yeah.